us as well as for all of you, it is the first in-person conference of this year. And as GPA President, as Mega GPCON organizing chairman, I feel proud that I am part of it. So today, for this pre-conference, we have a beautiful team of both chairman of pre-conference, Dr. Deepali Mule, as well as Dr. Manisha Khedkar. And along with them, we have stage in charge, Dr. Deepa Wagh and Dr. Deepa Doshi. Along with them, we have chairpersons for today, which we will be introducing them during the session. So this whole team has prepared a lot to present a beautiful scientific content, which is prepared with help of our scientific committee chairman, Dr. Prakash Mahajan sir and Dr. Praveen Darat. जसं सायंटिफिक कमिटी महत्त्वाची असते तशाच प्रकारे डेलिगेट कमिटी ही तेवढीच महत्त्वाची असते, कारण सायंटिफिक कंटेंट तेव्हाच लागू पडतो जेव्हा डेलिगेट्स असतात. सो फॉर डेलिगेट कमिटी, Dr. Kushal Mahajan has taken extraordinary efforts to make this delegates count reach to the expected number. So along with that, of course, my office bearers, both my secretaries, and none other but my Priyadarshini team, they all have been working really hard to make today's day come true. So without any delay, I would request the committee to start with their today's session. I once again welcome you all. Thank you.
डॉक्टर दीपाली मुळे यांनी BHMS PGDEFM केले असून स्पोर्ट्स न्यूट्रिशनमध्ये विशेष प्रावीण्य प्राप्त केलेले आहे. गेली 15 वर्षे जांभूळवाडी आंबेगाव येथे त्या कार्यरत आहेत. डॉक्टर मनीषा खेडेकर या BMS असून लक्ष्मीनगर पर्वती येथे गेली 15 वर्ष फॅमिली फिजिशियन म्हणून कार्यरत आहेत. अपलिफ्ट इंडिया आणि अन्नपूर्णा या NGO बरोबर त्या कार्यरत आहेत. आता पुढील कारवाईसाठी मी डॉक्टर दीपाली मुळे आणि डॉक्टर मनीषा खेडेकर यांना व्यासपीठावर यांची विनंती करतो आणि कार्यभार सोपवतो.
Thank you, Dr. Joshi sir, for your kind words and introduction. Good afternoon all. I, Dr. Deepali Mule, and co-chairman Dr. Manisha Khedkar, welcome all the COVID warriors in the auditorium. We were very eager and are very happy to see all the delegates here, as we all are meeting almost after 10 to 11 months for this scientific feast today. This year 2020, last year 2020 was very different and difficult, but we all accepted new normals. GPA President Dr. Rupa Agarwal and her team members really worked hard during this pandemic to keep all of us updated with COVID-19 as well as other topics with ongoing webinar. There was no gap in our learning process. So keeping our education and updation going on and on, we all are here today. Today, we will be listening to 5 different lectures. First is infertility to fertility by Dr. Amol Lunkad, then hypertension by Dr. Sachin Lakde sir, then viral hepatitis by Dr. Dada Saheb Maindad, neurological examination in our GP practice by Dr. Nilesh Palasdevkar, and pediatric cases by Dr. Sanjay Mankar. We have tried to cover different attending the CME online as well. So let's update ourselves with today's multi-focus topics from last lecture. Last lecture by Dr. Mankar is case discussion and going to be interactive with rapid fire round. As we say, we are meeting today physically, but we can say this first lecture going to be a step that a speaker is online and we are here physically present. So this is the step one, and then we will be having the physical presence of all the speakers onwards. I invite co-chairman Dr. Manisha Khedkar to conduct the further.
Thank you, Dr. Joshi sir, for your kind words. Thank you, Dr. Dipali Mole. Good afternoon, all, and warm welcome. Before we start for the actual session, there are some announcements to be made. Please kindly put your phones on silent mode. It's a request to all the delegates. In case of unavoidable calls, please take your calls outside the auditorium. Kindly take care of your belongings and mobiles, etc. Organizers will not be responsible in case of any losses or theft. Please be seated in the auditorium till the end of the session, as it's going to be a very elaborated till the end. Moving, as Dr. Mule rightly said, it's going to be a nice session. So starting with Dr. Lunkar sir's lecture, Infertility to Fertility, Scope of GP. It is definitely going to be a very heart-touching topic for me as a lady GP. So definitely, as we all know, sir is a very good orator, whether he is physically here or online. I welcome Dr. Lunkar sir. To chair this session, I welcome our chairpersons, Dr. Arundhati Kulkarni and Dr. Vaishali Loda on stage. Welcome both of you. Dr. Arundhati Kulkarni, she is a very senior Ayurvedic practitioner practicing at Araneshwar since last 22 years. She is running her own Panchakarma center in the area. Practicing since 24 years at Pimpale Gurau. She is running her own, interested in Garbha Sanskar and Yoga therapy. She is founder of Om Namo Parivartan Parivar. With this brief introduction of both the chairpersons, I hand over the charge to Dr. Arundhati Kulkarni for the further proceedings. Thank you.
Hello. Thank you, Dr. Manisha Khedkar, for the kind words. Today we are going to learn about the latest scientific techniques about the most sensitive topic, fertility to infertility to fertility. And we, as a general practitioner, knowing about the scope of the same. Let me introduce now with our speaker today, Dr. Amol Lunkad. Dr. Amol Lunkad is MD OBGYN from AIIMS Delhi, DNB OBGYN, MICOG and MNMS fellowships, diploma in advanced gynae endoscopy from Germany, chief IVF specialist at Indira IVF, founder member of Gynae Endocrine Society of India. Now let us know about his awards and achievements. He has awarded prestigious Indumati Zaveri Prize for Best Research Paper in 2010 by All India Congress of Obstetrics and Gynecology. Also awarded the Suli Rudra Sinha Prize for the Best Advanced Gynae Endoscopy Surgery by Federation of Obstetrics and Gynecology of India in 2010. Awarded the Best Oral Paper Presentation at the National Conference on Gynae Endocrinology 2011 held at New Delhi in April 2011. He is author and co-author for 28 national and international research papers and chapters.
Yes, good afternoon. Am I audible? Dr. Arundhati?
Yes, sir, you are audible. Please go ahead.
Yes, good afternoon. Thank you. Thank you for this opportunity. I thank GPA Pune for this mega GPCON and allowing me to interact with you all. Respected Chairperson Dr. Arundhati and Dr. Vaishali, thank you for your kind words and for your kind introduction. I will be speaking regarding infertility, and I will be covering in the next half an hour, trying to tell you how to evaluate an infertile couple, how to diagnose them, how to treat them, and what are the various treatment options. I bring you greetings from Indra IVF, the largest fertility provider nationwide, nationally the largest fertility provider. Let us begin. Infertility, as we all know, is the inability of a couple to conceive naturally even after 1 year of regular cohabitation without use of any contraception. And this is the standard definition of infertility. What I want you all to take home is this 1 year period where we have to wait, where the couple tries naturally, should be reduced to 6 months, especially if the female if the female partner's age is 35 years or above, if there is a known case of ovulatory disorder or severe PCOD in the female, if there is known history of genital or abdominal tuberculosis prior, if there is a known case of moderate to severe endometriosis prior or any ovarian surgery prior, and if the male partner has any history of testicular surgery, then in such couples, we won't wait for 6 months. We will start investigating them, helping them after 6 months of natural try itself. What are the various types of infertility? It can be classified into primary infertility and secondary infertility, depending on whether there was a prior pregnancy or not. It can also be classified into subfertility or absolute infertility, depending on the various causes of infertility. We all know that infertility is on a rise. 1 in every 6 couples requires help to achieve pregnancy, and this is mainly due to lifestyle changes, pollution, sedentary lifestyle habits, addictions, obesity, stress, delayed marriages, and delaying of childbirth, excessive use of contraception, and many countries are having a negative population growth now. So the incidence and prevalence of infertility is continuously on a rise, and it has become you can say a universal problem nowadays. And as I said, 1 in 6 couple requires help to achieve pregnancy. Now let us see what are the various reasons of infertility, or what are the various causes of infertility, both in the male counterpart and in the female counterpart. The most important thing to understand is the causes are equally prevalent both in the male counterpart and the female counterpart, and it is very easy to evaluate the male counterpart. So always remember, whenever an infertile couple comes to you, the male counterpart has to be evaluated first. What are the various reasons of infertility in the male counterpart? These reasons, for simplicity, can be classified into pre-testicular causes, testicular causes, and post-testicular causes. The pre-testicular causes will be various causes which involve the hypothalamus, the hypothalamo-pituitary testicular axis. So various causes involving this will be covered in the pre-testicular causes of male infertility, and those would be hypogonadotropic hypogonadism, Kalman syndrome, various tumors involving the pituitary or the hypothalamus or the pituitary stalk. Then there can be various hormonal disturbances in the male counterpart causing decreased efficiency of spermatogenesis in the testes. In the testicular causes, there can be various factors affecting the testes, like the primary testicular failure, where the spermatogenesis itself is deficient from birth, or secondary testicular failure secondary to infections like mumps, orchitis, tuberculosis, or exposure to various chemotherapeutic agent, exposure to radiation or radiotherapy, and various infections like hydrocele, piocele, those can again, or tuberculosis can again affect the testes and cause inefficient spermatogenesis and thus cause male factor infertility. Then there will be post-testicular causes, those causes affecting the epididymis, the vas deferens, the ejaculatory duct. So congenital absence of vas deferens is the most important cause in the post-testicular regions of male infertility. Then there can be retrograde ejaculation. So you will find sperms in the urine of such males, but no sperm in his ejaculate or the semen. And there would be various factors affecting the erection and ejaculation in the male counterpart, which will hinder them from having a good natural intercourse, and thus also a problem in achieving natural pregnancy and thus lead to infertility. Coming to the male counterpart, so the female counterpart, the various reasons of infertility in the female counterpart can again, for simplicity, be classified into pre-ovarian, ovarian, and post-ovarian causes. In the pre-ovarian causes, various factors affecting the hypothalamus, the hypothalamo-pituitary ovarian axis, and PCOD or hormonal disturbances, hypogonadotropic hypogonadism, and various tumors affecting the pituitary are the most important reasons in this segment. The ovarian causes can be primary or premature ovarian failure, or a primary ovarian failure, or ovarian cyst, endometriosis, or various infections causing oophorytis and causing premature ovarian aging. Genital tuberculosis is again an important cause of female infertility, and it affects not only the endometrial cavity, the fallopian tubes, the ovaries and the ovarian reserve, but also the pelvis and the pelvic anatomy and the tubo-ovarian relationship. In the post-ovarian causes, various factors affecting the fallopian tube, hydrosulfings, pyosulfings, are tubal blockages, and tubal factor infertility is an important cause. Then various factors affecting the endometrial cavity, the Asherman syndrome, genital tuberculosis causing adhesions in the endometrial cavity, repeated DNCs causing affection of the cavity, fibroid uterus, adenomyosis. So these are the various reasons of infertility in the female counterpart. In the female counterpart, you can roughly divide the reasons as ovulatory will be around 25%, tubal factor around 30-35%, pelvic factors, PID, pelvic inflammatory diseases, chronic endometritis, and endometriosis will all come in pelvic causes, will be again 30-35%, and few will be unexplained reasons. So what is most important is to know the reason of infertility. Proper evaluation of the couple is the most important thing. And if the evaluation is proper, then only our treatment is going to be accurate and would give us the best results, and will be consistency in our results and success. So as in all cases, the evaluation starts with proper history, examination, and then investigations. Here also the various histories which are important is the history of cohabitation, then coital history is important, duration of and frequency of coitus, any problem with intercourse, that has to be clearly asked for and documented. Routine history like the menstrual obstetric history, medical, surgical history, drug history is all going to be important. History of any contraceptive usage, history of consumption of eye pills, any history of previous PID or sexually transmitted diseases, thyroid or breast illnesses, any breast swelling in the past, any history of galactorrhea or excess of hair growth or hirsutism, acne. Occupational history is again important because exposure to various radiations, exposure to a lot of heated environment, is going to affect the gametes. Addictions in the couples is also important. So history is very important because it is said, rightly said, that listen to your patient. They themselves are giving you the diagnosis, and according to diagnosis will be our treatment. Examination of the couple. The important things to note is the BMI, then of course any signs of androgen excess like acne, hirsutism, excess of hair growth, acanthosis nigrans, neck and breast examination, neck examination for any lymphadenopathy, because tuberculosis is again a very common reason of infertility still in Southeast Asia and India. Galactorrhea and breast lumps, a good per speculum per vaginal examination, husband to be checked for smell sensation. As I said, Kalman syndrome is an important cause of azoospermia or male factor infertility, gynecomastia or virilization, and even the external genitalia and scrotal examination in the male partner. After history and examination comes investigation. After the routine investigations like serologies for the husband and wife and HB electrophoresis to rule out any thalassemia carrier or sickle cell carrier status in husband and wife. Another routine examination. Important is the thyroid prolactin levels, the rubella immunity status. If she is non-immune, then we can vaccinate her before going for treatment. And then coming to specific investigations in an infertile couple. Specific investigations would involve examination of three important things. The first and foremost thing to evaluate is the sperm or the semen, that is the male counterpart. And in the semen, we not only have to look at the external characteristics of the semen, its volume, its pH, but also its motility, morphology, in detail. The morphology will involve the examination of the head, the neck, middle piece, and the tail. So all this has to be looked into detail, and it has to be looked into detail according to the WHO 2010 criteria. Using the Newborn chamber is not allowed. It has to be by using the Mackler's chamber, and it has to be the morphology has to be documented according to the strict Kruger's criteria. The normal values are as follows. Semen volume should be at least 1.5 ml, and sperm count should be at least 15 million per ml. Total motility, progressive and non-progressive, should be at least 40%. Sperm morphology, semen in the morphology, at least 4% sperm should be normal according to the strict Kruger's criteria. And leukocyte count or pus cells less than 1 million per ml. So these are the parameters which have to be strictly adhered to, and a good detailed semen analysis will tell us almost everything about the male counterpart. So that is essential before we move ahead to other investigations in the couple. The second most important thing to evaluate is the egg or the oocyte in the female. And for evaluation of the oocyte or the egg, we have to do two important tests. Test for ovarian reserve and test for ovulation. Now, to test for ovarian reserve, to know how much capacity the female has left with her to produce eggs, it will tell us about how aggressive we should be in our treatment form. If she is having a lesser ovarian reserve, I will be more aggressive in treating her because she has less eggs left with her to achieve pregnancy. If she has a very good ovarian reserve, that means we can take time and we can try with less aggressive forms of treatment prior and then go to aggressive forms. So for knowing the ovarian reserve in a female, the most important tests are antral follicle count and serum AMH. So antral follicle count is a sonography test. By doing a transvaginal sonography on any day of menses, we can count the number of antral follicles in each ovary between the diameter of 2 to 10 mm or 2 to 9 mm. So these antral follicles will tell us about how many good eggs the female can produce at a time in her menstrual cycle, or what is her reserve left with her. So if any ovary is showing 5 or more follicles, antral follicles at a time, that ovary is suggestive to have a good or a normal ovarian reserve. While in the right hand side on your picture, you can see a ovary where you can see only a single antral follicle. So this ovary has a diminished ovarian reserve or a poor ovarian reserve. So if both the ovaries have normal ovarian reserve, then the female is having a good ovarian reserve. If both the ovaries are having a diminished ovarian reserve, then the female is having a poor ovarian reserve. Second most important test for knowing the ovarian reserve in the female is the AMH, or the anti-Mullerian hormone levels. It is a biomarker done by serum blood test. It can again be done on any day of the cycle. So that is the advantage of AMH. It can be done on any day of the menstrual period, because there are very less intracycle and intercycle variation in the levels of AMH. And AMH is basically the member of the transforming growth factor beta family. It is produced by the granulosa cells of the preantral and the small antral follicles. It is a direct marker of the primordial ovarian follicular pool. So it tells us about the ovarian reserve. It is undetectable in females at birth, slightly increases thereafter till puberty, and then it peaks at late puberty, and then again starts to wean off and becomes undetectable at menopause. The levels are constant throughout the menstrual cycle. So that is the advantage, and that is why it has replaced FSH, LH as a marker of ovarian reserve, because FSH has to be done on day 2, day 3 of the menstrual cycle. Again, intercycle, intracycle variation in FSH levels are too high. So AMH has replaced FSH as a marker of ovarian reserve. And as I said, AMH is the best biomarker to know the female's ovarian reserve. Now going to test for ovulation, whether she is ovulating properly or not. We have looked at whether she is having a good ovarian reserve or not. Now we'll look at whether she is ovulating or not. To know regarding ovulation, the best thing to do is to do a folliculometry, that is the serial ultrasounds, to check how the serial transvaginal ultrasound, to check how the egg is forming, how a dominant follicle is formed, and how it ruptures to give ovulation. And rupture can be basically documented by seeing the subsequent collapse of the dominant follicle and free fluid in the POD. Of course, not all ovulations, not 100% ovulations can always be documented. We have other methods of looking at the ovulation. And the second most important thing is the serum progesterone levels. Serum progesterone levels done on day 21 of the menstrual cycle, or 7 days prior to the presumed menstruation, if the values are more than 10 picomole per liter, then it is suggestive of ovulation. So simple 1-point test to know whether the female is ovulating or not. Of course, you have urinary LH search kits which can be used to know whether ovulation is occurring or not. We can know ovulation is occurring or not just by the history. If the menses are regular, more or less the female is likely to be ovulating. Then the basal body temperature is again another way by which we can see, because we know around LS surge there is a rise in basal body temperature also. The third and last important thing to evaluate is the uterus and the fallopian tubes. And to evaluate the uterus and the fallopian tube, the most important thing to do is do a simultaneous transvaginal, transabdominal 2D and a 3D scan. This will give you more or less all details about the pelvis, the pelvic anatomy, the antral follicle count, the endometrial cavity, the endometrial volume, the ovarian volume. All this can be easily known on presence of any space occupying lesion, any fibroid, adenomyosis, any endometrial polyp, or any hydrosulfings. All these things can be easily, the shape and the size of the uterus, all these things can be noted on a good transvaginal pelvic scan. Also, to know regarding the patency of the fallopian tubes, we can do a saline infusion sonography or a sonosalpingography or even a hysterosalpingogram, which is a X-ray which we do. Then again, in selected cases, we might require laparohysteroscopy to treat any lesion, or in certain cases of unexplained infertility to know the proper cause. To evaluate regarding genital tuberculosis, we might require endometrial aspirate for tuberculosis, which can be tested by a PCR or by a bactec culture. As I said, tubal patency can be evaluated by HSG, which was an age-old X-ray, where we used a dye and looked at the not only the endometrial cavity, but also the tube and its patency. Here you can see the various films, where a baseline film, where we see the uterus, then the initial part of the tube, and then finally the spill, which establishes the patency. Here you can again see HSG, where bilateral complete hydrosulfings can be seen with blocked tubes and normal uterus. Saline infusion sonography or sonosalpingography is a very good test to dynamic test. It has more or less replaced the age-old HSG or hysterosalpingogram. And here not only we can evaluate the patency of the tubes without use of any X-ray or radiation exposure and without use of any contrast. So multiple advantages, and now more and more infertility specialists and gynecologists have stopped doing HSG and moving towards saline infusion sonography and a sonosalpingogram. It gives a dynamic visualization. We basically introduce a 6 French Foley's catheter, a very small pediatric Foley's catheter, into the uterine cavity and push a normal saline, which is pushed. It will fill the uterus. You can see it simultaneously on your transvaginal scan. Then it will fill the fallopian tubes, and the saline or the saline mixed with various contrast materials can be seen coming out through the femoral ends and shows the patency. It will also help us to evaluate the endometrial cavity and the tubes dynamically throughout the procedure. So HSG will give you a momentary picture. Unless you are doing HSG with a fluoroscopy guidance, then only it is comparable with saline infusion sonography or a sonosalpingogram. If we are doing it just momentary picture, then we cannot compare. Here we get many more information. So here you can see uterine pathology is being delineated well. You can see the hydrosulfings being delineated. So it will give us a dynamic visualization of not only the endometrial cavity, but also the tubes and its patency. In the uterine assessment, we need to check all these things: the shape of the uterus, the size, intracavitary region, adnexa, and the endometrium also. So we have to rule out congenital malformations, fibroids, adenomyosis, polyps, any adhesions, intrauterine adhesions, fibroids. So these are the things. Here you can see a sonography showing a fibroid uterus. Here there are multiple calcified adhesions in the cavity. Here you can see a beautiful endometrial polyp. Again, intrauterine synechiae or adhesions can be seen here. So all this evaluation has to be done in great detail to understand about the pelvic anatomy and the uterus. Rarely, as I said, in certain cases, we might require to take help of hysterolaparoscopy. The take-home message should be not all infertile patients require hysterolaparoscopy. It is only in those patients where we have found some space-occupying lesion, or where we want to correct the lesion hysteroscopically or laparoscopically. There only we are going to basically use hysterolaparoscopy. Also, in certain patients where it is completely unexplained and undiagnosed, no reason of infertility, then we can use hysterolaparoscopy for diagnosis and for treatment of various causes of infertility. Here you can see hysteroscopy being performed. We nowadays usually use a 2.5 French hysteroscope, and more or less it is a daycare procedure. You evaluate and visualize directly the endometrial cavity. Here you can see fundal adhesions being present at the fundus. You saw both the ostia, the tubal ostia, the inner openings of the ear. You can see one ostia. It is plucked by the endometrial plaque. So, and you can correct also. Now here you can see the fundal adhesions being dissected or cut so as to release the adhesions and do betterment of the endometrial cavity and improve our chances to achieve pregnancy. Laparoscopy we do to visualize not only the pelvic anatomy and the tube-ovarian relationship and the tubal patency, but also to correct any abnormality. Now here is a rare case where you can see a double uterus on laparoscopy. So you can see two uterine horns, and both the horns have a fallopian tube and an ovary. So such rare pelvic variations can be better evaluated and confirmed on laparoscopy. Here you can see the right horn with the right tube and ovary, and then the left horn along with the left tube and the ovary. So that is the role of laparohysteroscopy. So after evaluation, we will find out the cause of infertility, and according to the cause will be the treatment. So our aim is to convert this education and knowledge into action to help our patients with proper treatment options. And the various treatment options can be from simple lifestyle modifications to use of various drugs for ovulation induction, use of various drugs to help the male partner improve his sperm quality and sperm count and motility, use of various drugs to achieve proper ovulation. There can be intrauterine insemination or IUI. There can be IVF or test tube baby. So there can be a whole range of treatment options. Depending on the reason will be our treatment. And as I said, there can be a various spectrum of treatment options which is available. Just simple lifestyle modification, weight loss, lifestyle changes, giving up of various addictions is also going to help the couple to get fertile. As it is rightly shown that even a 5% weight loss causes almost 90% females to ovulate. So anovulatory infertility patients can start ovulating with weight loss and diet management and better lifestyle changes. Of course, coming to ovulation induction, which is a major chunk of infertility treatment, all patients who are having anovulatory infertility or who are having ovulatory cycles, but we want to super ovulate them so as to increase the chances to achieve pregnancy. So there we use ovulation induction. So ovulation induction is nothing but use of various pharmacological treatment and agents to induce ovulation in a patient with anovulation or oligo-ovulation. And we also do super ovulation using ovulation induction agents in ovulating females so as to increase the probability to achieve pregnancy by producing more than one egg. So as we know, WHO has classified ovulatory dysfunction into 4 categories: hypothalamic pituitary failure, that is hypogonadotropic hypogonadism. And in these patients, the FSH-LH would be subnormal, the AMH would be normal to subnormal. They will have peculiar history of getting menses only on withdrawal, and they will have a normal antral follicle count. And we have to give them HMG or FSH-LH combination to achieve ovulation and pregnancy, because their pituitary is not functioning. There is hypogonadotropic hypogonadism. The gonadotropins are not being released, and that is why externally gonadotropins have to be given to achieve ovulation and fertility. Hypothalamic pituitary dysfunction, these are normogonadotropic type of patients, and PCOS forms the major chunk of these patients. And so PCOS is the most common reason of anovulatory infertility in female. The ovarian failure can be there where the eggs have finished, and there can be last category of hyperprolactinemic anovulation. So almost 30% of female infertility is due to anovulation or oligo-ovulation, and here ovulation induction plays a major role. We use various oral agents like clomiphene citrate, aromatase inhibitor like letrozole, anastrozole, or other selective estrogen receptor modulators like tamoxifen. We use injectables like human menopausal gonadotropin or follicle stimulating hormone, or we use a combination of these agents along with various adjuvants like metformin, myoinositol, antioxidants, coenzyme Q10. All these things can be used in either alone or in combination to use achieve ovulation induction. So you have various agents your aim is to achieve ovulation, and in ovulatory females achieve super ovulation. So there is no hard and fast rule. You can do mix and match of these agents as you want to achieve ovulation or super ovulation, depending on your case to case. Now, clomiphene citrate, a age-old ovulation induction agent, which have been used. It is a selective estrogen receptor modulator, and it basically acts on the estrogen receptors and block the negative feedback mechanism of the estrogen to FSH, and thus causing excess release of FSH and ovulation and recruitment of more follicles. Standard, it is given 50 milligram for 5 days, starting from day 2 to day 6 of the cycle for 5 days. We can increase the dose up to even 200 mg, but always start with a lower dose. Always do a baseline sonography before starting ovulation induction. Always monitor follicular growth by serial sonographies or folliculometry once you have given ovulation induction. Always document ovulation whenever you are giving ovulation induction drugs and agents. Whether you are starting on day 2, 3, 4, or 5 of the cycle, it will give you the similar results. Earlier, so tamoxifen, again, selective estrogen receptor modulator used for ovulation induction. It gives similar results to clomiphene, but does not have the anti-estrogenic side effects on the endometrium, so it does not cause endometrial thinning. Coming to aromatase inhibitor, letrozole, anastrozole, they basically again basically they inhibit the aromatization of testosterone to estrogen, and that is how they basically reduce the peripheral estrogen levels, and thus the negative feedback of estrogen to FSH is inhibited, and there is excess release of FSH to cause follicle recruitment, growth, and ovulation. So they have been very well used. They are very good agents. Letrozole is the most common agent which is used, 2.5 milligram to 7.5 milligrams for 5 days, starting from day 2 to day 6 of the cycle. And it has the advantage of it does not cause endometrial thinning. It does not have anti-estrogenic peripheral side effects. It does not cause cervical mucus thickening. All this is seen with clomiphene and not seen with letrozole. It causes monofollicular development, so hyperstimulation is less. It is the agent of choice for as a first-line agent in patients with PCOS. So these are the advantages of letrozole over clomiphene citrate. It is superior to clomiphene citrate in clomiphene-resistant PCOS patients, and it does not cause basically less chances of hyperstimulation and causes monofollicular development. We can use gonadotropins like HMG, FSH, or LH to induce ovulation induction and superovulation. These are injectables. They can be used alone or in combination with the oral agents. So, and you have various protocols to use them, the step-up protocol, the step-down protocol, or in combination with the oral agents, low-dose protocols, or the conventional dose protocol, and the dose would be decided depending upon the AMH, antral follicle count, BMI, and previous response to stimulation. Along with ovulation induction, there can be timed intercourse or there can be IUI. IUI is nothing but introduction of washed spermatozoa into the uterus above the level of internal os around the time of ovulation. It reduces vaginal hostility, it bypasses the cervix and bypasses the sexual contact, and we deposit the sperm directly near the ovulation site. In patients where we use IUI, can be in coital problems, in patients with mild to moderate male factor infertility, oligospermia, asthenozoospermia, teratozoospermia, in patients with unexplained infertility or mild to minimal to mild endometriosis, in HIV discordant couples. All these are the indications of IUI. Coming to IVF or in vitro fertilization or test tube baby, as we all know, Louis Brown was the first IVF baby of the world, born on 25th July 1978, and it has been more than you can say 43 years since she was born, and 80 lakhs plus test tube baby have been born after her. And it is a now quite a age-old technique which is used to help the infertile couple. So the basically Louis Brown mother had both the fallopian tubes blocked because both her fallopian tubes were blocked. That is why scientists like Dr. Steptoe and Dr. Edwards that time thought that because the fallopian tubes are blocked and not working, the fusion of the eggs and the sperm are not going to occur naturally. So let us unite them artificially outside in laboratory in proper environment, and that is how IVF came into being. And in last 42 years, we have been using this for various other indications of infertility. So this 1978 technique of IVF was replaced by ICSI in 1992-93, and the difference was in IVF we used to basically keep the egg in a petri dish and expose it to few thousands or few lakhs of sperm and allow the fertilization to occur naturally. While in ICSI we are directly fusing each good egg with one good sperm to achieve embryos. So direct fusion of each good egg with one good sperm under the microscope is ICSI. Here you can see ICSI being live ICSI being done. You can see under the microscope, this is a mature egg. We come to know about the mature egg by the polar body which is released. So this is a mature egg. Under the microscope, by holding pipette, we hold the egg, and by the injecting pipette, we inject one good sperm directly into the uterus to achieve fusion of egg and the sperm to achieve pregnancy. So ICSI when and how? So ICSI has basically IVF for ICSI. There are various steps. We will do superovulation by using gonadotropins. We'll retrieve these eggs outside to form multiple embryos by doing fertilization, and we'll reposit back these embryos into the uterus to achieve pregnancy. So there will be a pre-assessment, then control ovarian hyperstimulation, ovum pickup, that is retrieval of the eggs outside, and followed by fertilization with sperm to achieve embryos, and then embryo transfer would be done to achieve pregnancy. So here you can see the, are you able to see this video?
Hello.
Yes. Am I audible? So basically, what I was saying were the indications of.
Hi, sir. This is the admin over here. So you have just 2 minutes left.
Okay, I will wind up in another 5 minutes. Just last 2-3 slides are left. So basically, indications of would be.
So you have already exceeded the time.
Yes, I will wind up definitely. So basically, I was saying were the indications of IVF for ICSI: moderate to severe oligozoospermia, asthenozoospermia, teratozoospermia, history of vasectomy or retrograde ejaculation. And in the female counterpart, if we see blocked fallopian tubes, hydrosalpinx, PCOS patients not responding to usual treatment, endometriosis or adenomyosis, failure of 3 or 4 IUI cycles, premature ovarian failure or aging, postmenopausal females wanting pregnancy, and post-tubectomy or post-ligation. So after ligation, the best thing to do is not to go for reversal of the ligated tube, but to directly go for IVF or ICSI and achieve pregnancy. And of course, unexplained infertility, not responding to usual treatment. Recurrent pregnancy loss is one important thing. Couples wanting PGD. Sexual dysfunction and serodiscordant couples. So all these are the indications of IVF or ICSI. And there have been various advancements in IVF ICSI which have taken place. Right from IMSI, we use a higher magnification of 6,000 times. Blastocyst culture, growing the embryo, not transferring day 2 or day 3 embryos, but to culture the embryos for 5 to 6 days and transfer more robust embryos. Do laser assisted hatching, that is to thin out the outer covering of the or outer shell of the embryo so that they implant easily and in a better way, so the success increases by 20-25%. This is the laser assisted hatching video being done. Then we have embryo biopsy, which can be done to know genetically normal embryos. So any patients with recurrent pregnancy loss, with translocations, with hereditary disorders, thalassemia, sickle cell anemias, here we can find out a genetically normal embryo and transfer it into the uterus to achieve pregnancy. Cryopreservation of the sperm, the eggs, the semen, embryos, all these things can be done to preserve your fertility. So this is the closed working chambers where we do ICSI to fuse the egg and the sperm and achieve pregnancy. We use various incubators. We use electronic witness system to tag the embryos electronically so that there is no mixing of gametes. There is always a manual double witness technique which is also followed. So these are the various techniques and technologies which we use while doing IVF or ICSI. And of course, the success depends on various factors, right from the egg quality, the sperm quality, and the transfer. This is our results in the last 6-7 years at our Pune center, my team at Pune center. And I thank you all for this interaction. And these are the few take-home messages for you from my side to convert an infertile patient to a fertile being. And the final aim is to achieve a happy family and to complete the family and to give parenthood to infertile couples. Thank you. Thanks a lot. Sorry, I exceeded my time. And thank you for accommodating me. I thank Dr. Rupa Agarwal Madam, Dr. Joshi Sir, Khedkar Sir, Dr. Darak Sir for giving me this opportunity. And thank you for my chairpersons. Thanks a lot.
खूप समाधान आणि आनंद देणारा असा टॉपिक आहे की इनफर्टिलिटी पेशंटच्या चेहऱ्यावरती फर्टिलिटी ट्रान्सफर करून
I request
सर्व सर्व मान्यवरांचे आभार. आता पुढील कारवाईसाठी आजच्या सेशनचे चेअरमन आणि को चेअरमन डॉक्टर दीपाली मुळे आणि डॉक्टर मनीषा खेडेकर यांना व्यासपीठावर घेऊन कार्यभार सोपवतो.
I request all the delegates to keep please first 2 rows for speakers and organizing committee members. It's my humble request because we have already alternate chairs and we really need the second row as well for speakers and committee members. Moving forward, as we said, we have covered the all day-to-day routine practice. The major chunk of our patients are hypertension. And for this lecture, the next speaker is Dr. Sachin Lakde sir, a humble personality. To chair this session, I request Dr. Gayatri Vahalkar and Dr. Sanjay Suryavamshi on the stage. Dr. Gayatri and Dr. Sanjay. Dr. Gayatri Vahalkar has done her BHMS. She is family physician and specialization in gynec and skin, and she is practicing since 15 years at Shastri Nagar, Kothur.
All Sahyadri hospitals and Inamdar Hospital. His interest lies in primary angioplasty, complex coronary angioplasty, and special interest in preventive cardiology with motto, prevention is better than cure. He has more than 15 publications in national and international journals and is also involved in field of research. He has been invited as chairperson and speaker in many national conferences. He is daily available from 4 to 8 p.m. at his private clinic, Hriday Sparsh Heart Care Clinic, located at Mitra Mandal Chowk, Swargate. Having its 3 units at Hadapsar, Vishrantwadi and Kharadi, which are looked after by Dr. Krishna Kumar Dut and Dr. Akash Modgi. He is director and owner of Cardiac Cath Lab and Cardiac ICU unit at Sangli also. He is an associate professor, Cardiology Department, Bharati Vidyapit Medical College, Pune, where he enjoys teaching PG students and guides DM and DNB students. I request sir to start with his presentation.
Thank you, sir, for that. Important in day-to-day life topic, which is very simple. We know this is one of the more mortality causing disease, and if we ignore at a certain stage, that can kill the patient over a period of time. It's a silent killer like a diabetes. So previous speaker has taken a little bit more time. I'll try to finish on time and finish the topic within 25 minutes. It's more of a discussion session rather than slides, because so many guidelines are there. We have our own guidelines, our practice. For me, I know there are lot many of थोड़ा interference होतो है याच्यामध्ये. Volume कमी करा. So if there are a lot many of European guidelines are there, Indian guidelines are there, so many guidelines which drug to give, when to treat hypertension, what should be the target. Many things are we have very confusing regarding this, and our own practice is there. To best of my knowledge, many of our practitioners, family physicians are treating hypertension much more than me in day-to-day practice. But I'll try to give the guidelines, which are international guidelines as well as Indian guidelines, which are guided by the after lot many of studies, what is relevant for hypertension in 2021. So I'll start with a simple case, a routine case, what we have in day-to-day practice. This is the male, 43-year male, middle age, mechanical engineer. काही symptoms नाही त्याला, फक्त routine examination we found out to so what are थोडं मला याच्यात व्हॉलेंटरी होत असेल किंवा you can tell the answer by group. In addition to lifestyle modification, which is the most appropriate steps of this patient? Just to give drug like amlodipine, telmisartan, metoprolol. Okay, ठीक है मैम. Telmisartan, metoprolol, or do something else. But I would like to highlight few more things. Just doing single blood pressure reading at your office doesn't matter. Just this was the start, and I'll show you a few interesting things why this blood pressure has to be evaluated properly. The day-to-day, the India has this was the Indian study of hypertension published in 2014. Almost 40 crore of 35 to 40 crore of Indian population is having the hypertension. So coming back to the case, my answer would be D. Do ambulatory blood pressure monitoring. Just don't rely on single blood pressure monitoring. You have to repeat the blood pressure many times, like 3-4 readings, home reading. All the clinic blood pressure readings will be high. आपण जर आपलं जरी ब्लड प्रेशर चेक केलं आपल्या कलिगच्या ऑफिसमध्ये म्हणजे क्लिनिकमध्ये तर ते जास्तच येणार आहे. सो ऑलमोस्ट 10 to 20 millimeters of mercury. So any office blood pressure is not reliable actually, and especially when it's not very high. So you have to repeat the blood pressure, and this is the internationally guided device where you measure the blood periodically blood pressure हा रिपोर्ट करतो आणि रूटीन ऍक्टिव्हिटी म्हणजे त्याचे तो जर वर्क मध्ये असेल त्याच्या रूटीन ऍक्टिव्हिटी मध्ये रूटीन मध्ये काही चेंज करायचं नाही पेशंटनं. अँड वी अनालाइज दी ब्लड प्रेशर आफ्टर 24 hours. It gives you idea about the systolic, diastolic blood pressure as well as heart rate. Even night time, daytime blood pressure is recorded. So this is like we can see the graph. This was the patient's graph where we can see many of the readings are in the hypertensive range, and when he goes asleep, his blood pressure is normal. Many things are guided, and especially when the patient has the doubt about the hypertension, or it's not a very severe hypertension. This is the this ambulatory blood pressure monitoring or home blood pressure monitoring remains the important before starting the any antihypertensive, and it's not very costly. It costs just 3,500 rupees. So many parameters are seen studied on this device, and then we start the treatment accordingly. It's more reliable than the isolated clinic blood pressure treating hypertension on just a few readings of the isolated clinic measurements, where the many of us are subjected to white coat hypertension. So this ambulatory and home monitoring of BP adds considerably to the diagnosis of the hypertension, and provision of optimal treatment care is done. So these are the differences. We can see the clinic blood pressure and the what we check on the ambulatory blood pressure and home monitoring of blood pressure. There is lot many patients are we see the readings. We can see the normotensive or ambulatory blood pressure. If there is sustained blood pressure, दोन्हीकडे blood pressure असेल तर patient is hypertensive. मास हायपरटेन्शन काही वेळा असं असतं की पेशंट मल्टिपल एका फॅमिली फिजिशियन कडून दुसऱ्या फॅमिली फिजिशियन कडे जातो आणि असं कन्क्लूड येतो की एकाकडे आहे दुसऱ्याकडे नॉर्मल आहे. मेनी टाइम ट्राय टू प्रूव्ह दॅट त्यांचा ब्लड प्रेशर नॉर्मल आहे, काहीतरी अँटी हायपरटेन्सिव्ह घेऊन येतो आणि तुमच्या क्लिनिकमध्ये सांगतो देर इज नो हायपरटेन्सिव्ह. And if you do ambulatory blood pressure for that patient might be hypertensive. And white coat hypertension only if there is hypertension at your clinic. असे खूप सारे पेशंट येतात की जे तुमच्या क्लिनिकमध्ये असतात, हायपरटेन्सिव्ह असतात, पण नेहमी घरी गेलो की माझा ब्लड प्रेशर नॉर्मल आहे. Those are not really hypertensive. Maybe in a future they could be hypertensive. For those patients, they are non-hypertensive, and those patients doesn't require antihypertensive treatment. So after this ambulatory blood pressure, we start the pharmacological treatment. But many of the things, it's not only starting. आपण खूप साऱ्या वेळा असं आहे की ब्लड प्रेशर डिटेक्ट झालं, हायपरटेन्शन डिटेक्ट झालं, जस्ट स्टार्ट दी अँटीहायपरटेन्सिव्ह ट्रीटमेंट. दॅट्स नॉट इनफ. खूप वेळा आपण असे लॅब इन्व्हेस्टिगेशन न करता जस्ट अँटीहायपरटेन्सिव्ह स्टार्ट करून hypertension treat करत असतो. तर we can see many of the things we have to find out. Or though patient might not do the investigation, patient करायचा नाही कदाचित आपण सांगितलेली investigation, but these are the mandatory investigations before any hypertensive. आपण खूप बघतो की हायपरटेन्शन 5 वर्षापूर्वी 10 वर्षापूर्वी डिटेक्ट झाले, पण एकदाही ब्लड टेस्ट केलेले नाहीत. आयदर थायरॉइड or sugars or urea creating. Many things can be ruled out, or can be those might be needed to adjust according to the lab reports, and patients are तर मी येतो पुढे येतो. Food eco is also mandatory. Food eco is also mandatory. लॉंग स्टँडिंग हायपरटेन्शन आहे का? सो इनिशियल चॉईस आपण डायग्नोज केलं, लॅब इन्व्हेस्टिगेशन्स दिल्या, तर मेनी ऑफ अस ट्राय टू गिव्ह अँटीहायपरटेन्सिव्ह, काय आता MR येऊन गेलाय त्याच्याप्रमाणे आपण अँटीहायपरटेन्सिव्ह थेरपी देतो. इट्स नॉट द वे टू. देर आर सम गाईडलाईन्स अँड दोज हॅव टू बी फॉलोड. सो इनिशियल चॉईस, फर्स्ट चॉईस कुठलंही कॉम्प्लिकेटेड हायपरटेन्सिव्ह नाही, तर दोज पेशंट शुड बी ऑन thiazide kind of diuretic, calcium channel blocker, ACE inhibitor or ARBs. This is the standard. आपलं आपण नॉर्मली असं आहे की खूप सारे बीटा ब्लॉकर्स लाईक मेटाप्रोलॉल किंवा ॲटेनॉल खूप फेवरेट चॉईस आहे. दिस इज नॉट दी प्रॅक्टिस इन 2021 where you should not start with this kind of antihypertensive. Usually below age of 55, ACE inhibitors or ARBs has to be used, and above 55 calcium channel blocker. म्हणजे वयाच्या these are the standard guideline, international guidelines, where पहिला म्हणून that patient was 43 years old. Few of them have advised the telmisartan or any ARBs of that kind, and the for age more than 55, calcium channel blocker like amlodipine are the recommended drugs. And beta blocker in sole should not be used as the antihypertensive. But the sir give ARBs. ARBs are the ARBs or ACE inhibitors. ACE inhibitors are of common enalapril and this thing ramipril causes dry cough. So better to give ARBs. Start with ARBs. So काय बीटा ब्लॉकर दिला किंवा अटेंड the patient who were on beta blocker. So better to not use just as a first choice of antihypertensive. We should not use beta blocker. न्यूअर कॅल्शियम चॅनल ब्लॉकर्स म्हणजे आपण आता खूप सारे अँटीहायपरटेन्सिव्ह अवेलेबल आहेत मार्केटमध्ये. तर it's not the just the control of blood pressure. We have to check about the beyond the blood pressure hypertension control, like target organ diagnosis म्हणजे stroke, त्याच्यानंतर then the renal dysfunction, cardiac LVS develop झाले का. So all these markers, proteinuria कमी झालं, or the drugs which are means old kind of drug, amlodipine doesn't causes that much, just control the blood pressure. So newer calcium channel blockers are available, which have shown better than the anti. It's not only the control of blood pressure, but the target organ damage is also reduced with this kind of antihypertensive. Even the pedal edema, which is more common with the non-pitting pitting edema kind of things, are there with the amlodipine. That's also less with the cilnidipine किंवा acildipine जे new antihypertensive market मध्ये आलेली आहेत. Benidipine is there. So I won't go in detail of this. So in general, what should be the target? म्हणजे कोणतं एक what should be the hypertension target for the patient? काही कोणी सांगेल का? 130/80. H plus 10. H plus 10 is not the definitely. So, risk factor and age. Age is the more important. More than 75, blood pressure should be age of 60 years, and patient with diabetes and kidney disease. What happens if you go very aggressively? Then also that's the patient have more CV events. So you should not very hard and fast rule. There are various guidelines. Some say 130 by 80, but 140 by 90 should be a target, and 130 by 80 for the diabetic and CKD patient. Those patients with having diabetes and blood pressure, diabetes and CKD, chronic kidney diseases, those patients, the blood pressure has to be below one. The target should be 130 by 80, irrespective of age for that. So another important factor is the lifestyle modification. आपण खूप वेळा आपल्याकडे पेशंट आल्यावरती आपल्या एवढ्या ओपीडी मध्ये गर्दीमध्ये आपण हे खूप महत्वाचं आहे की लाईफस्टाईल मॉडिफिकेशनच पेशंटला ऍडवाइस करतो. जस्ट प्रिस्क्राइब द अँटी हायपरटेन्सिव्ह लॅब इन्व्हेस्टिगेशन्स बट insist every time for the weight reduction. Even the 10 kg of weight reduction gives almost 10 to 20 millimeters of mercury reduction in blood pressure. Eating dash diet is the salt restricted diet. त्याच्यानंतर fruits, then vegetables, green leafy vegetables, all those things. If you see physical activity itself can, many patients are don't do the exercise regularly, and just doing the physical exercise for 30 minutes in a 5 to 6 days, in a 4 to 5 days in a week, that can reduce the blood pressure by 10. So all this has to be insisted. So even if the patient does this kind of lifestyle modification, and that blood I won't go in detail. When the patient has diabetes, these are guidelines. The target of choice is ARBs, ACE inhibitors, or calcium channel blockers. Then patient with ischemic heart disease, there comes the role of the beta blockers. The blood pressure first line of choice is there with the beta blockers and calcium channel blockers. Few of the, I won't go in detail of the pregnancy, but in general आपण शक्यतो patient physician किंवा cardiologist कडेच refer करावा for the pregnancy with hypertension, pregnancy induced hypertension. And we all know there are very few drugs where we can use alpha methyl-dopa, nifedipine, and the levodopa. These are the only drugs to be used in the pregnancy. Just a interesting case, 32-year-old female diagnosed to have hypertension 3. एवढे ड्रग्स चालू होते, amlodipine 10 BD, telmisartan 80 milligram, hydrochlorothiazide, metoprolol. Still the blood pressure was uncontrolled. काही additional investigations किंवा renal doppler पण normal होता, thyroid function पण normal होतं. BNP लेवल सर जास्त इम्पॉर्टन्स नाही राहत त्याच्यात, हार्ट फेल्युअर पेशंट मध्ये जास्त राहतं. VMA level, correct sir, that was also normal. VMA should be also tested for the patient. Diuretic, yeah, diuretic should be there is already chlorothiazide. So this patient had coarctation of aorta, which was diagnosed on the echocardiography, 2D echo. And just that treating the coarctation on just by stenting, her antihypertensives have been stopped. So it's very thing that kind of sorted of should be tested. These are the common causes for this secondary hypertension. Cushing. Very rare causes are also there, but we have to find out, and should this kind of patient should be referred to the specialist. So आम्ही तर असे खूप almost 15-20 cognition of aorta केलेली आहेत की ज्याच्यामध्ये either the patient has stopped, young patient who was on hypertensive or 4-5 antihypertensive, and hardly one or two antihypertensive, or they have stopped the antihypertensive after doing the coagulation stenting. So other causes like sleep apnea should be also evaluated. Then coming to resistant hypertension. Resistant hypertension is the term defined when the blood pressure of his blood pressure remains more than 130/80, and the patient is on 3 antihypertensive at maximum dose that include diuretic, and many things should be evaluated this patient. Many things have been again insist on the lifestyle modification for this kind of patient, and more important is the just giving the aldactone like drug that also helps to reduce the hypertension. Hypertensive crisis. Hypertensive ज्यावेळी ब्लड प्रेशर 180-120 च्या वरती असतो, पेशंट asymptomatic असेल तर there is no, it's a kind of urgency, you can treat hypertension slowly. But if the patient has a emergency, like patient is having headache, nausea, vomiting, those patients need admissions and should be treated accordingly. So I'll skip a few slides because of time. Just to summarize and conclude, जरी आता एक 20-22 मिनिटं मी बोललो असेल तरी बाकी काय ऐकलं नसेल use whenever required the ambulatory blood pressure monitoring. Then always insist on self gives the blood pressure reduction of 20 to 30 millimeters of mercury, and it has to be we have to take time as a family physician. We have to take at least 5 minutes to explain about the lifestyle modification whenever the patient at least has first time detected hypertension, or if the hypertension is not controlled. Then always do the lab test, do ECG, look for ECG, look for LVS, do 2D echo, find out if required any coagulation like abnormalities are there, and special tests like for secondary hypertension whenever required. The appropriate pharmacology. Don't give just blindly any treatment. Recommended guidelines आहेत, and the best for the patient. Always prefer that drug, antihypertensive drug, and whenever you use fixed combination, when म्हणजे ज्यावेळी पेशंट कडे आपण मल्टिपल ड्रग्स असतात, try to give the combination so the compliance becomes better. So always use the fixed combination, and resistant hypertension patient send it to the specialist.
Any questions from the audience?
Huh? Yes, sir. No, fixed drug is always preferred. When the suppose the telmisartan 40 झाले आणि 5 milligram amlodipine, use the combination. It's always better for the patient compliance. But you can get that But the again, we should not just that, because it can cause more of episodes. Postural hypotension can be there, so it's better to target that blood pressure of around 150 and give drug like calcium channel blocker, which are smooth acting and with less chances of postural hypotension. Sir, once in a year doesn't matter, sir. Hardly we have so many of patients on diuretic. Nobody. It's very, very low. Then use hydrochlorothiazide. Thiazide, like yeah, uh, yeah. No, no need required for the antihypertensive. If it's very means the patient has vomiting, nausea, then only use the hypertensive medicine. Yeah, we have to give. We have to give. Uh, nahi, nahi, nahi. Just cooling down the patient. It's more of alcohol withdrawal symptoms. Sir, alcohol withdrawal symptoms असतात ना, many times the blood pressure gets accelerated with that. Sir, associated systolic hypertension खूप common असतं. Diastolic is in young. Systolic
Sorry
you
to
have to
interrupt you,
treat
sir.
and target the blood pressure of
Sorry to
150 by
interrupt
9.
you, sir. Time is over. Sir.
हो I know. खूप क्वेश्चन असतात हायपरटेन्शनच्या टॉकवरती, आणि रिअली मेगा जीपीकॉनच्या ऑर्गनायझरनी खूपच चांगला टॉपिक अगरवाल
As a family physician, it is very important role to diagnose the patient or to investigate hypertensive patient. Going to help us to manage the hypertensive patient and to investigate patient at proper stage and at very early stage. Thank you, sir, for such a precise lecture.
Hello. Thank you, chairpersons. Now I invite Dr. Shivaji Kolle, sir, organizing co-chairman Mega GPCON 2021, to felicitate today's speaker, Dr. Lakde, sir. Lakde, sir, please be on dais. Thank you, Lakde, sir. Your last slide, really, it was very informative and elaborative with very simple words. I request Kolle, sir, to felicitate chairperson, Dr. Gayatri, madam. Gayatri, madam. Thank you. Our second chairperson, Dr. Sanjay Suryavanshi, sir. Thank you, Lakde, sir. Thank you all. Please be there. by respected Dr. Dadasaheb Maindad sir, who will be speaking on approach to viral hepatitis, and Dr. Bhalchandra Kadam on stage. Welcome both of you. Dr. Swapnali Wadekar, she is BHMS, practicing as homeopathy consultant at Kasbapet since last 15 years, joint treasurer of PDA in the year 2016-17, first chairman of PDA Anandi Mahila Manch, felicitated by Honorable Mayor for her social work. Our second chairperson, Dr. Bhalchandra Kadam, BMS from Poddar College, Mumbai, practicing at Shivne Uttam Nagar since last 20 years, founder of USDA, and he's been president for that Doctors Association since last 5 consecutive years. With this, I hand over the charge to Dr. Swapnali Wadekar for further proceedings. Over to you, Swapnali. Thank you.
Thank you, Dr. Manisha Khedkar, for the kind introduction. Now I invite the Dr. Dadasaheb Mendad sir on the stage for the lecture on approach of viral hepatitis. He is the MD Medicine from Government Medical College Miraj and DNB Gastroenterology from KMC Medical College, Manipal University. He is the practicing in Nextigen Multi Specialty Center, Decision Tower Satar Road and Nextigen GI Center, Anand Nagar, Sinhar Road. He is the assistant professor in medical gastroenterology at Bharati Vidyapit and consultant at Sahyadri Hospital, Global Hospital and Rao Hospital. Now I request the sir to please start your lecture. Thank you, sir.
हॅलो, आवाज येतोय? गुड आफ्टरनून एव्हरीबडी. थँक्यू मॅडम, अग्रवाल मॅडम, दरक सर, सगळ्यांनी मला अपॉर्च्युनिटी दिली. मी जास्त बोर नाही करणार, फास्ट घेतो थोडंसं. आज मी थोडं डिटेलमध्ये जाणार आहे व्हायरल हेपॅटायटिसच्या बर्डनवर, बिकॉज दिस इज व्हेरी कॉमन डिसीज अँड वी आर ऑलवेज नेग्लेक्टिंग द डिसीज and many times we are not guiding patient properly. First time whoever the patient presenting with jaundice, he will come to your clinic, and if he will not receive proper treatment, he can land into the trouble. Just one day before, I saw one gentleman who is well educated from Sangli, and he is diagnosed as hepatitis B in 1992. So now it is almost 30 years back, and he never evaluated. He was not under any follow-up. So that is a good luck of that patient that he is not landed into the cirrhosis or hepatocellular carcinoma. So what is mean by hepatitis? It is just inflammation of the liver due to any cause, due to the infection, due to the drugs, due to the autoimmune conditions. So these are the infective causes. We all know that there are 5 types: A, B, C, D, and E. There are 2 viruses got transmitted by fecal-oral route, A and E. B, C, D will get transmitted by the sexual, unsafe needles and blood products. So what are the other causes of hepatitis? Like I told, autoimmune hepatitis, drug-induced hepatitis, alcoholic hepatitis, and inherited disorders like Gaucher's disease and so many storage disorders. And the most common right now whole world facing is a non-alcoholic steatohepatitis.
there were 315 outbreaks in India, and most of them saved from corona because we are unhygienic. We are having very good immunity. We are suffering from so many infections since our childhood. If we'll go into any book, we are called as a tropical countries, and there are so many tropical infections like that. Hepatitis A and E is very endemic in India. So hepatitis A is responsible for 10 to 30% of acute hepatitis and around 50% of acute liver failures. Similar, hepatitis E causes 40% of acute hepatitis, but the acute liver failure rate is little bit higher than the hepatitis A. Hepatitis E is very dangerous in the pregnancy, especially in the third trimester. There is very high rate of the fulminant hepatitis up to 25%, and death rate is up to 20%. If there is a jaundice with pregnancy and hepatitis E is positive, we have to be very careful. And if there is a ACLF, it is called as acute on chronic liver failure. If some patient is having already some liver disease, he is chronic liver disease due to hepatitis B, due to alcoholic liver cirrhosis, and if he will develop the hepatitis E virus infection, his liver cell reserve is very less, and he will land into the acute failure. So that the mortality will be increased drastically up to 60%. What about hepatitis B? Like hepatitis A and B, here also we are not behind, and we are having 1.4 million deaths in 2010 due to hepatitis B and C. Around 40 million Indian population is affected by the hepatitis B. And highest prevalence is seen in the Andaman Nicobar and Arunachal Pradesh. Hepatitis B leads to 20% of the hepatocellular carcinoma. Usually hepatocellular carcinoma occurs in only cirrhotic livers. Are some outbreaks still happening in the India due to the due to type of acute hepatitis B epidemic was occurred in the Gujarat due to the unsafe needle use in the healthcare practice. So this is the what we are facing for the hepatitis C. In India, there is around 1.5 to 3.5% population is affected by hepatitis C. So we are 135 crore. If we will just consider the 4% of our population is affected by the hepatitis C, just consider the number, how huge it is. And we are on the 4th number all over the world for hepatitis C. As we are different from world in hepatitis C. Everywhere there is a genotype 1 is common, but in India there is genotype 3. Hepatitis C is divided into 6 genotypes. We will require genotype to treat the hepatitis C. Without knowing the genotype, it is difficult to treat. So if we go by the genotype, we are having type 3 genotype, which is predominant. We all saw the movie Udta Punjab. That movie is on the drug addiction and IV drug use. So it is very common in the northern states like Himachal Pradesh, Punjab. So what is the presentation of hepatitis? Any hepatitis, hepatitis A, B, C or E. It could be asymptomatic. It could be fulminant hepatic failure or symptomatic disease when patient is presenting to us, or chronic hepatitis, and sometimes a typical presentation. Means patient directly present to us with ascites, hepatocellular carcinoma or extrahepatic manifestation or simple deranged LFT on the routine evaluation. And then we will go back retrogradely and we will find that that patient is suffering from some type of hepatitis. So patient will present to us with these 5 types of Phase 2, when patient will present to us with symptoms like anorexia, fever, arthralgia, or pruritus. So usually patient will present to us with these features. So phase 1 is asymptomatic, phase 2 is symptomatic, phase 3 is ectric phase. This is a second phase when patient will come to us after taking a lot of homemade remedies. He will present to us with dark urine, pale color stool due to the cholestasis, icterus, and right upper quadrant pain secondary to the hepatomegaly. That pain will not be severe, just the lacking, dragging type of pain will be there. And phase 4 is recovering phase. So in this phase, patient features will resolve, but icterus will take time to resolve. Sometimes it takes 3 months to 6 months. So be assured that patient, don't worry, if you are okay, you are taking, your appetite is fine, you are not getting fever, your malaise is not there, headache is not there, then nothing to worry about the yellowish discoloration of the eyes. This is a chart which showing half-life of, incubation period. Usually hepatitis E occurs, hepatitis A occurs within a 30 days from the infection, hepatitis B within 60 to 90 days, and hepatitis C also within 50 days. Hepatitis B and D usually occur simultaneously. They are called as a dependent virus. Hepatitis E is called as dependent virus. Either it will occur as a co-infection or super-infection. And hepatitis E incubation period is 40 days. So I will not go through this table. Everyone know that there are so many things. So many times patients are coming to us with hepatitis, acute hepatitis B or hepatitis B, and they will ask, doctor, I got this yellowish discoloration of eyes, my hepatitis B test is positive, what is the next? How we should prognose permanent hepatitis. So we have to monitor them closely, but assure them that there is a chance the virus will get cleared completely from the body in 95% of the patients. But there is different story with the children's. If the baby will get infection in his childhood, the chronicity will be around 90%. 90% baby will get converted into the chronic hepatitis B. So please avoid the transmission from mother to child is very important. Today only one lady came to me. She is hepatitis B positive. Unfortunately, she delivered in rural hospital. Her baby is 3 years old. Now he is hepatitis B positive. Just consider remaining life is 97 years for that baby, and that baby has to uh, be there for next 97 years with hepatitis B, and she has to follow repeatedly to the doctor. She can develop hepatocellular carcinoma, cirrhosis of liver, and so many things. So mother to child transmission we have to prevent. As I told, chronicity is depend upon different things like age, as well as if the hepatitis B and hepatitis D infection occur simultaneously, chronicity will be more. Prenatal transmission from mother to child, chronicity will be 90%. Hepatitis C is having chronicity more than hepatitis B. Again, hepatitis B and hepatitis D co-infection, chronicity is 10%, and only hepatitis B chronicity is 5%. Similarly, permanent hepatitis occurs with superinfection in hepatitis E in the pregnancy, and patients those are having those are having chronic liver disease. What is the common presentation? Everyone know that jaundice is a commonest presentation. On examination, we'll get the hepatomegaly. We'll get this finding in 70 to 80% of the patients. Other findings like splenomegaly, lymphadenopathy, arthritis, vasculitis, these are the rare presentation of the hepatitis A and investigation in the form of LFT. So we'll get the idea how much LFT is deranged, and the give importance to the bilirubin. If HOT and SGPT in thousands, kindly monitor every day. LFT has to monitor every day if it is more than 1000. If it is 500, you can monitor every third day. See, for the INR, it will again give us idea about the how much is a cellular reserve in the liver and how good is our liver in the form of synthetic function. Go for the complete blood count and viral markers, HIV and HIV IgM, to confirm your diagnosis. Also go for the ultrasound abdomen to rule out any extra hepatic obstruction for your bile duct. Treatment is symptomatic. Just ask them to rest, soft diet, avoid smoking, alcohol, give antiemetic, antacid, and so all the drugs. Remember, there is very great taboo in India. Whenever there is a jaundice, people will modify diet drastically. They will give just rice and dal. That's it. With salt. No oil, no masala, nothing. If I will start eating it for next 14 days, I will lose a 10 kg. It is, I'm damn sure. So if some person is suffering from the disease when his caloric requirement is high and you are giving such a blind diet, he will not eat. Just in previous slide, I told that the taste is altered. That patient is not having taste and you are asking them to just eat rice and dal. So the most of the patients are becoming more sick and sick secondary to these taboos and diet modification. Whenever patient coming to us, I am telling them start eating everything except non-veg. So we will go for the HBV infection. So what is the presentation of hepatitis B? Hepatitis B present to us in a different forms like acute hepatitis B. Just I told 95% patient will get recover without any treatment. 70% patient will be asymptomatic and they will directly present us to either in the on evaluation will get idea that this patient is hepatitis B positive and he is since a long duration. Now he is exacerbated due to some secondary insult, and that insult could be either due to the immunological seroconversion or viral reactivation or due to the add-on virus infection or some drug. So hepatitis B is having 4 stages. First stage is a immune tolerant phase. In this phase, viral DNA will be high and ALT will be less because our immunity is not that strong that immunity will fight with the virus. Why AST and ALT increasing in the hepatitis B? Because virus is not killing the hepatic cells, but whenever there is a fight between hepatitis B and our immunity, the bystander hepatic cells, hepatocytes will die, and so that the AST ALT will increase. In children's, immunity will not be very good, so that this virus will survive very well without any problem, and so we'll get the ALT normal. Now here there is no cell death because there is no fight. But if you'll go into the immunoactive phase, as child grows, his immunity will develop and there will be seroconversion. Now there is a fight between immunity and hepatitis B virus, so that we will get low virus. Now virus are dying and our AST ALT is rising because of the hepatocyte death. And this is the time when you will get the exacerbation and patient can land into the hepatocellular failure. Again, once your viral load will go down, secondary to your immunity, then both will do the settlement. So there will not be any fight and there will not be any increase in the ALT. If there is a reactivation, again there is a fight. Whenever there is a fight between our immunity and hepatitis B, then our liver enzymes will increase and only we have to intervene between these phases. There is no need to intervene this phase. form. So in immune tolerant phase, we'll get the high viral load, the intermediate viral load with elevated enzymes. In carrier phase, we'll get the less viral load with normal ALT, and in immune reactivation, again viral load will increase and ALT will increase. So phase 2 and phase 4, we have to intervene. So how to evaluate this patient? Go with the clinical examination, then go for the LFT, AST, ALT, bilirubin, albumin. So albumin will give idea about the chronicity of the disease, and bilirubin and AST, ALT will give idea about the recent insult to the liver. See for the hepatitis, confirm with HBS antigen, go for HBE antigen, HBE antibody, and HBC antibody. HBC antibody give us idea about whether this disease is acute or chronic. If hepatitis B core HBC IgM will positive, it is acute or exacerbation of the hepatitis B. And if hepatitis E antibody is positive, means patient is quite in the settled condition. He is developing antibody. So if hepatitis E antigen is positive and antibody is negative, they are more prone to get a reactivation. And if hepatitis antibody is positive, means they are already, there is a seroconversion and patient is now in the carrier state. So we will require these different types of antibody and HBV DNA viral load, because we want at least 2 evidences to start the treatment. One is LFT and one is DNA viral load. And these rest of the antibodies we will require to identify the exact phase of the hepatitis B. Then go for ultrasound abdomen, look for the cirrhosis of liver, portal hypertension, hepatocellular carcinoma. Alpha fetoprotein again is a marker for hepatocellular carcinoma. The most important is fibroscan and liver biopsy. What I told in the last slide, if there is a fight, we have to intervene. Of hepatitis B, the patient will land into the acute on chronic liver biopsy. If there is a fibrosis more than grade 2, leave everything and start treatment. If some patient with hepatitis B coming to me with ascites, there is no need of anything. I have to start antiviral on day 1. Then I will evaluate with viral load and all those things, ultrasound, everything. But if cirrhosis is there, directly start antiviral. Why we have to prevent, screen and treat the hepatitis B? Because it is communicable and vaccine is available, so we can prevent it. Again, this is a life-threatening. It can cause multiple complications. It is treatable. Available drugs are very good, having less resistance, and they are very cheap also. Whom to treat? As I told, there are 2 things we have to be very sure that patient is having chronic hepatitis B, means the duration of hepatitis B should be more than 6 months, or there should be some evidence of chronic hepatitis B like cirrhosis, portal hypertension or something. And we will require either high viral, we will require high viral load, derange LFT, either these 2 or high fibrosis. Keep in mind only high fibrosis or either these. So diagnose as early as possible and start treatment. There are very good antivirals available like entecavir and tenofovir. We have to start the antiviral and they will be there for lifelong, because this virus will not get eradicated from the body, and that virus will be there for your whole life. If patient is cirrhotic, consider supportive treatment in the form of partial banding, ascites management, good nutrition. And if patient is in a decompensated state or healthy. If it is normal, just follow. If it is abnormal, go for the treatment. For this criteria is cirrhosis, either in compensated or decompensated state, liver failure, extrahepatic manifestation, and family history of hepatocellular carcinoma. These are the exception to routine criteria. Those patients we started the treatment, we have to follow up them. They have to visit us every 3 months with LFT. If patient is whether on treatment or off treatment, we have to check the LFT. If patient is on treatment, we have to see whether patient is doing well. If his LFT is getting deranged, means he is getting something, some other insult in the form of other viral infection, or he is taking some drugs, or he is not following proper our instructions. And if patient is not on medications, means if his LFT is deranged, means there is a reactivation. Every 6 months, we have to go for ultrasound, alpha fetoprotein, and HBV DNA viral load. This alpha fetoprotein and USG abdomen is for the hepatocellular carcinoma, because there is a 30 to 40% chance of hepatocellular carcinoma in hepatitis B without cirrhosis. So we have to monitor for the hepatocellular carcinoma, diagnose as early as possible. If patient is having only hepatitis B without cirrhosis, we can resect the hepatocellular carcinoma. So early diagnosis, if lesion is small, we can resect it. But if we are not monitoring the patient is presenting to me with 10 centimeter of tumor, I have to go for the liver transplant.
Excuse me, sir. Last 5 minutes.
Yes, sir. Finish. So I will, this is a HBV infection in pregnancy. Many times pregnant ladies are getting screened for hepatitis B and HIV routinely nowadays, and they are coming to us with hepatitis B positive report. If they are on, if they are having active disease, means they are having deranged LFT and high viral load, we have to treat them. If they are not having active disease, we have to monitor them every 3 monthly, do repeat viral load at 28 weeks. If it is more than 2 lakh, hepatitis B only, either in acute phase or either in exacerbation with on incidental chronic liver disease or extrahepatic manifestation. Here there is no any criteria whom to treat. Every patient with hepatitis C we have to treat. And evaluate patient with hepatitis C antibody. Hepatitis C antibody many times gets either false positive or false negative. So don't believe on hepatitis C antibody. If you are very highly suspicious, go for the HCV RNA and go for the genotype, because treatment is depend upon the HCV RNA and genotype. So these are the different drugs available. Soposabovir and velpatasvir is a pan-genotypic regime. There is no need of any genotype for this regime, but please don't use this regime, because there is 10% resistance with any antivirals with hepatitis C. If patient will develop resistance to this regime, there is no second regime available in all over world. So please don't use these regimes as initial treatment. As we are Indians, we are having most common genotype 3 and genotype 4. Go with soposabovir with ledipasvir first. If they are not responding, then go for the soposabovir with velpatasvir. These are the drug doses for the anti-HCV drugs. And what is the outcome? Hepatitis B will not get cured. Rest of the viral infection like A, C, E will get cured. The most important is how to prevent. Hepatitis A and E is a route of transmission is fecal-oral, so good hygiene will prevent the transmission, and safe blood, avoiding unsafe sexual relations, needle sharing, tattooing, vaccinations against the hepatitis B, and mother screening will prevent the hepatitis B infection. Thank you.
charge to session in charge Dr. Manisha Khedekar, ma'am. Thank you.
Thank you, Dr. Kadam. I request Dr. Rupa Agarwal, Madam, Organizing Chairman, Mega GPCON 2020-2021, to felicitate our speaker, Dr. Dada Saib Mahindad, sir. Yes, yes. Thank you, sir. It was very simple and lucid presentation. Thank you, sir. Please be seated in the auditorium. Our second chairperson, Dr. Kadam, sir. Dr. Swapnali Wadekar.
Hello.
Please be there for a minute for a group photo. Thank you so much. Thank you, Rupa Madam. There are some announcements regarding tomorrow's main conference. All delegates are requested for tomorrow's conference. Please be present sharp on time. We'll try to start it by 9 a.m. All delegates are requested to visit all pharma stall tomorrow. We are going to have lot many attractions in tomorrow main conference. So please attend the whole conference. Be present till the end because lucky draw prize will be declared at the end of the session. Following prizes fourth lecture on neurological examination in G are on stage. For this, we have two chairpersons, Dr. Sayani Gandhi and Dr. Ganesh Nimbalkar, sir. I welcome both of them on stage. Dr. Sayani Gandhi completed her BAMS from Solapur in 2013. She is practicing at Varje Malwadi since last 3 years and she has done PGDMS from Ruby Hall Clinic. Second chairperson, Dr. Ganesh Nimbalkar, sir, BHMS practicing at Sai Prasad Hospital since last 20 years at Guzarwadi Fata Katras, past secretary of PDA Association and trustee of Asha Foundation since last 20 years. With this, I hand over the charge to Dr. Gandhi. Thank you.
Thank you, Dr. Manisha Khedkar, ma'am. I invite Dr. Nilesh Parasdevkar, sir, on the stage for a very interesting topic, neurological examination in general practice. Dr. Nilesh, sir, has done his MBBS from BJ Medical College, Pune, and DM Neurology from KEM, Mumbai, with gold medal. He trained in epilepsy surgery and neuroelectrophysiology. Currently, he has passed brain and spine clinic at Mitramandal Chowk and attached to Mauli Nursing Home Dhankaudi, Ruby Hall Vanauri and Nobel Hospital as well. I request to Dr. Nilesh sir to start with your lecture.
Good evening. It's really a pleasure to see you all of you back once again after this corona pandemic. As we all know that physical meetings have almost stopped and we were all meeting each other only virtually. But thanks to our efforts of all our medical fraternity that we are back again to the normalcy, and this is the first meeting that I am doing personally or physically, and so I take this opportunity to congratulate all for that. All of us with all our support we could come out of this global pandemic well, and think this is a topic of a workshop where we can go regarding the neurological examination for at least 2 hours. So if actually we had a detail, and I feel that Dr. Darak sir will definitely organize something in that way in coming future, so that we can learn the neurological examination in detail. Right now, what I am going to speak with you is not the detailed neurological examination, because in our day-to-day practice, it is not possible for us to complete the neurological examination in 5 to 10 minutes of interaction that we have with the patient. So there is an art in this neurological examination where we, rather than doing a detailed examination, we can do certain things and use a neurological examination more judiciously, more smartly. Whatever we need to diagnose for a patient, whether it is a set of investigations, whether it is to come at a diagnosis, tell him the prognosis or treatment, we can do it in a short while, not more than 5 minutes. Okay, so let us understand how a neurologist does a neurological examination. We will today be seeing the art of neurological examination. So let us first understand what is the science of it. Neurological examination, basically the nervous system is probably the largest system in our body. Usually we say the largest system is skin, but in each and every skin we have got nerves in it. So the neural nervous system is widespread. It is a large gamut of 6 billion neurons, their interactions, their circuits, and as we all know that it includes the brain, spinal cord, root plexuses, nerves, NM junction muscle. Anything else to add to this that will come in the nervous system? Okay, so the most important thing that I feel that we neglect is mind. Okay, so the mind is also part and parcel of our nervous system, and traditionally, scientifically, if we need to do the neurological examination, it is a very lengthy examination. So you have to check the mental status, the cranial nerves, the motor system, reflexes, the sensory system, coordination and gait. So if we go on doing this in our regular practice, it is going to take at least half an hour to do a detailed neurological examination. But frequently, this is not required. If you see the neurological examination, it is going to be, it is one of the lengthiest examination. It seems quite tedious, can be time consuming, over, and sometimes even it depends on the mood. It can be moody. It can depend on the mood of the patient as well as the examination. So today I was seeing the dashboard. So the dashboard in my clinic, it usually tells me what patient I am seeing in last say 6 months. Okay, so 75% patients which I had seen, they were of headache, they were of vertigo, they were of Parkinson's. In most of these patients coming to me in my day-to-day practice, the CT scans and MRI are going to be normal. So how am I going to diagnose this patient? How am I going to treat them? So in such cases, the MRI and the CT scans are really not going to be helpful. So after the history, your neurological examination is probably the most important thing that will help you arrive at a diagnosis and treat the patient. Though it appears to be very tedious, it can be mastered with practice. So if you keep on practicing it, you are definitely going to be perfect. It can be used as a screening tool. So when I say screening tool, from an examination, what you can say, whether this is neurological or it is non-neurological, whether it is a serious condition, it is a non-serious condition, whether it requires investigation. So if it requires investigation, what shall I do? Shall I go for an NCV test? Shall I go for an EG? Or shall I go for an MRI? At least that you should understand. It should not happen that the problem is somewhere else and you do some other investigation. For that, it can be used as a screening tool. And first and foremost, probably it is extremely rewarding for the patient. When you do a detailed examination, the patient is really very happy. You know, most of the what usually we don't touch the patient, we don't examine them. So once you do that, the patient feels the डॉक्टरांनी at least मला तपासलं तरी. Patient are telling me की असं मला कोणीच तपासलं नव्हतं. So that is extremely rewarding, and when you diagnose something that can't be diagnosed on anything else but by your detailed history and diagnosis, that as a clinician, as a physician, it is extremely rewarding. So let us understand, let us be an artist, and let us see how we chart is you should have certain things with you, and that should be of a good quality. You should invest a good amount. Torch, sorry, it is not shown here. You require a hammer. It should be a knee hammer. You should require, you will have require fundoscope, and you require a cotton ball or a pin prick to test the sensation. This is a basic thing that all of us should be having handy when we are seeing a patient and we are planning to do a neurological examination. Okay, so before, how do we reach to a neurological diagnosis? Suppose the patient is suffering from epilepsy. What are the most important steps before that we can arrive at a diagnosis? The first and foremost over there is clinical history. Listen to the patient, listen what he is saying. Whenever the patient enters you and he starts speaking, it is at that time you start examining him and the neurological examination begins. But history is the most important thing. What we learn from history, we will see in a short while. Once you know the clinical history, you should decide in your mind that what you have to see in your examination. There should be some knowledge about the neuroanatomy and neurophysiology. Then we see where is the lesion, what is the cause of the lesion, and then probably we can form the differentials and reach to diagnosis. So the most important thing is going to be your clinical history and the examination. Okay, so whenever we are taking history, what a neurologist seeks. So we know the neuro axis. For example, if somebody comes with a foot drop, all of us understand, we'll take this case of foot drop to understand this basic concept. If somebody comes with a foot drop that he can't lift his leg, okay, so if somebody comes with a foot drop, there could be multiple causes from where this foot drop is going to come. It can come from the peroneal nerve, it can come from the sciatic nerve. Peroneal nerve is at the fibula, sciatic nerve is in the hip. It can come from the alpha radical, that is in the spine. It can come from spinal cord anywhere, or it can come from the brain. So now when I see a patient with foot drop, the first thing that comes into mind is why he has developed foot drop, why his left leg is not coming up. So that is the question that comes into mind. So where is the localized, where is the lesion, from where is this foot drop coming? That it is coming from the brain. Next, if somebody goes to lift something and all of a sudden he develops a, so I know that this foot drop is probably coming from the spinal cord. If somebody sits for a cross leg for a very long time, they're traveling in a congested car, or they're traveling in a train, they're playing cards in the train for a long time, and then he comes with a foot drop, then I know that this could be a pressure palsy. So we have to understand on the history that where is the lesion, and then probably what is the lesion. It occurs suddenly, all of a sudden. Anything sudden in medicine comes from Shanardar. It is always vascular. Okay, so it has to be stroke. Somebody loses his power, speech, all of a sudden, so that has to be stroke. If this foot drop is coming over a period of time, लहानपणापासून थोडंसं चालायला त्रास होतच होता, कधी पायातून चप्पल निसटून जायची, बऱ्याचदा ठेचकावून पडायचा. So we know that this history is long standing. So this might be something neurodegenerative lesion. So ask the patient. So once from the patient you know, now this patient probably has a foot drop that is coming from the spine. So now I know what to examine. In that case, probably if I don't examine his cranial nerves, that is okay. Okay. So at the end of history, for in this patient, you have to form a hypothesis. So there should be something in your mind that you have now decided. Now this is what is going in your mind. This seems to be most likely diagnosis. Recognize the pattern. As I told you, the pattern is extremely important how the patient present. So suppose somebody comes with wrist drop, and I know that he's an alcoholic and he had slept on his hand yesterday night. So I know this pattern very well. So most probably he's having a radial nerve palsy. So recognize this is a pattern. In your mental, make a plan. Now before you get up, what shall I examine in this patient? So if he has got a L5 radiculopathy, what are the muscles which are again supplied by L5, which I need to check? Okay, so I need to know something about the neuroanatomy. I need to know something about the neurophysiology before I start examining the patient. So we should know what is the purpose of our examination. So if the patient comes with any single problem and I start from the cranial nerve, mental stresses, I am never going to comes with a acute back pain, I know that the muscles affected are all supplied by. So I know that this is only coming from the L5 radiculopathy. But if the patient additionally, I check his gluteus, I check his hamstrings, that are also weak. So I know now this can't be only L5. So this can be the sciatic nerve. Okay. If the patient comes with acute onset foot drop, I ask him to close his eyes and I see that slowly his hand is also going down. So this can't come from the sciatic nerve. It has to come from the brain. So you have to see what are the other accompanying features. Why it is important? Suppose somebody comes with a peroneal neuropathy. Probably if you do a scan of brain, nothing you are going to find. So for that patient, you need to subject him to the EMG. If somebody comes with the L5 radiculopathy and you do a MRI brain, again it is not going to help. So before deciding MRI spine, you should know that this is definitely coming from spine. So we are using it as a screening tool. The thing is 100% based on your clinical examination, but it is going to help you which test to advise, right? So this is a brief neurological examination. Probably we can do each and every patient. So whenever the patient enters in your clinic, you should understand how is the patient. Does he look sad? How is he walking? Is he interested in visiting you, or the relatives have pulled him and they have brought him to you? See how he is looking at the surrounding. Ask him, greet him. Ask him certain questions. See how he is walking. See how is his face. See how is his clothing. Somebody who is depressed, they would be very shabbily dressed. Somebody who are having maniac, there would be very gaudily dressed. By that you can just understand what is the state of mind at that patient the moment he enters your clinic. Patients with dementia feel that they don't have any problem. It is the relatives, they are pulling them to the neurologist. So प्रत्येक गोष्टीचं उत्तर मला काहीच त्रास झाला नाही. That is what going to they do. So we will look at how the face looks, how is the head, how is his posture, how are the lower limbs, and how are his sensations. So this, if we decide, it doesn't take any longer than 5 minutes. And with some general examination like the pulses and blood pressure, mostly any serious disease we are not going to miss. We will go. Once the patient his feet while he is entering, so what it could be? So it can be, this is something called as high steppage gait. So either the patient with foot drop, so he will have to lift his foot up, okay, or it comes with vitamin B12 deficiency. Why? Because their nerves are damaged, they can't get sensations from their feet, so they will trying to stamp the feet to get the sensations more and more. Okay, so just by the patient, the way patient walks, you can make out what the patient is having. If he comes with a mask faces, we know that this is Parkinson's. There are certain neurological diseases where there would be balding, there would be loss of temporalis. So you see the patient and you know what that patient is there. So look at the patient. Your simple observation is going to help you reach the diagnosis earlier. Okay. So if you tell me two things that I would like to, if you tell me as a neurologist, only two systems you have to examine, and then we want to see whether you can diagnose. So I will tell, I just want to see the patient walking, and I just want to see the patient talking. The speech and the way the patient walks probably helps the diagnosis many disorders that we see in day-to-day practice. We will try to see some things in detail. Okay, so let the patient speak, greet them. When you greet them, काय कसं काय बाबा, कसं वाटतंय, बरं वाटतंय का? So depending on that, depending the way they answer, you can check their speech, you can understand how their mood, and ask simple questions. काय कसं काय आला तुम्ही, कुठे राहता, आज दुपारी काय खाल्लं, सकाळी कुणाला कुणाला भेटला होता, आज कोणवर आहे. By these simple questions we are trying to assess the mental condition of the patient. See what are how the patient answers. If the patient answers in simple words, they are disinterested. कधी कधी ते सर्व गावाची सगळी बातमी सांगायला लागतात. Okay, so you can understand that their mood is very jolly. See the way they are pronouncing, whether when they are speaking, how is the speech. There is something called as spastic. जसं की तोंडामध्ये they have kept something laughing, or they will just start crying. That is something called as emotional lability. Can be muscular Parkinson's, and see the tone, the way of speaking. Parkinson's patient will speak in very low voice. Somebody who has got chorea, there would be different intonation. The way they speak will help us understand what are the issues, how is their memory, depending on their thoughts, their words, the actions. That will tell us about their character and definitely destiny of the patient and the doctor. Okay. Next thing, look at the eyes. Okay. When you speak with the patient, see whether they are blinking properly or not. You have seen so many patients coming with early facial palsy. Just look at their blink and you will see that one eye is not blinking properly. Okay. Why? Because that is the earliest sign of a Bell's palsy. So that we are going to see a lot of Bell's palsy. Just you see that one eye is blinking, one eye is not blinking. This palsy has to be 100% going to be element palsy. It is not going to come from stroke. No use of doing MRI in this patient. Right? So just looking at eyes, you know that this is a Bell's palsy. MRI you can tell the patient that this is 99.99% not a stroke, and then you will probably recover in a month. So look at the symmetry, see how they are blinking. Look at the eyes, whether there is any obvious squint. And secondly, you can see the eye movement in all the directions. Okay, so whether he can see sideways, whether he can see up, whether he can see down, whether he can see. So if you see the eye movement, that will tell us when he thinks about the brainstem. Ask them to close the eyes tightly. Okay, if the patient is not able to close the eyes tightly, that again is a sign of facial palsy. See for any nystagmus, fundus, if you can see the fundus, and definitely always a pupil. Okay, so in eye movement, see the blinking. Sometimes what will happen with Parkinson's patient, they will not blink. They will appear as staring at you. Okay, normally in 1 minute we blink 12 to 14 times. But patient of Parkinson's is not going to blink. They are just going to stare at you. That is classical mask faces. Okay, so look at the eyes, look the way they talk, and look at the face. Again, see whether the face is symmetrical, as I already told. See whether there are any mask faces. See whether when they smile, where they laugh, when they see the teeth, is there any deviation? See रहते म्हणजे 4 वर्ष झाले डॉक्टर मला चालताच येत नाही. ओके, अँड देन यू आस्क, किती वेळा पडलेला, you are not walking properly, nobody has told, and then you ask them to walk, they will as it like a drunken mind, but they will never fall. Okay, that gait itself, that is called as ataxic abasic gait, that usually comes with psychological. So in gait, you have to see if the both arms are going properly or not. There would be decreased arm swing. A Parkinson's patient will not move one arm at all, where one arm will move. Same will happen with a patient with stroke. See what is the base of the gait. What does it mean? Base of the gait is how much distance they keep between the feet. Okay, if somebody is unstable, they can't stand with feet closed, so they try to keep their feet apart. So if somebody is standing with feet apart, probably that is called as wide basic gait. They are not stable. Then look at the heel strike. That again is important in foot drop. Time spent on each leg. Again in Parkinson's, they will walk rapidly. Okay, so each step has got very small time. See the posture, whether, and simple test to take the distal muscles is knee walking and toe walking. Okay, so walk, ask them to walk on in their heel, ask them to walk on your toes. If they are able to do this, there is no significant distal muscle weakness. So you can rule out a neuropathy. In neuropathy, motor neuropathy, it will start distally. They will complain that their footwear or their slipper they come out. But if the patient is walking on their toes and heels properly, probably there is no significant distal weakness. Next, what we can tell, ask them to sit down, squat, and get up, or ask them to sit on a chair, put the hands on your head, and then get up. So that rules out any proximal muscle weakness. So anybody who can toe walk, heel walk, and get up from squatting position, he doesn't have a significant lower limb weakness. Similarly, in hands, ask them to close the eyes. If there is no drift, then probably these patients, they don't have any significant proximal upper limb weakness. So rather than testing power at each and every muscle, reading it 1 to 5, in less than 1 minute, you can check the power of significant muscle. So this is art of neurology. just by seeing walking, you can check the motor system, you can check the cerebellar system, you can mind. So in a 2-minute test, probably 4 important aspects of neurological examination we have completed. Okay, so this we have already Parkinson's. We know a patient with hemiparetic paresis will walk this way. So you already know that he has got a stroke. Acute ataxia would be walking like a drunken man. Ataxic abasic. Again, I told you that they will try to fall but never fall. And waddling is like a duck. They will walk this way. Okay, why? Because there is hip weakness. That can again happen with pregnancy. That can again be seen with muscle disorder. So somebody who comes waddling in your clinic, probably you feel that this patient is going to have a muscle disorder. And high steppage gait, I already told you, can be seen with foot drop or posterior column lesion as seen in vitamin B12 deficiency. Okay, now this is a very important concept, especially for us when we are going to advise certain investigations to the patient. So this we have to know. So I have included that is something called as upper motor neuron lesion or lower motor neuron lesion. So our neuro axis has got two kinds of neurons. One is the upper motor neuron that is present in the brain and the spinal cord, and beyond that, that is the root, the plexus, the nerves, the muscle, they come in lower motor neuron. So when the patient has got these lesions, they will present differently. Okay, so for example, in upper motor neuron, the tone would be increased, while in lower motor neuron, the tone would be decreased. If you see the reflexes, the reflex set would be exaggerated in upper motor neuron, and they are going to be absent in the lower motor neuron. The plantar or the Babinski, that is going to be extensor in upper motor neuron, and it is going to be normal or absent in the lower motor neuron. Only these 3 points you remember: the reflexes, the Babinski, and thirdly the tone. Why this is important? It depends on what investigations you advise for the patient. Okay, so if somebody comes with the upper motor neuron lesion, you are sure that this is an upper motor neuron, you straight away go for an MRI. That MRI can be MRI of the brain or MRI of the spine. Each and every examination. So it's simple. Just see the tone, see the reflexes, and see. Depending on that, probably you can ask for an MRI or an EMG. Okay, so this is what we have seen. So see for the mental status of the patient, the face, the adventure facial movements, which we already see during the history taking. You need not spend any extra time for that. See how patient enters your room, see the gait, see his stability. Take the, as I told you, for lower limbs, ask heel walking, toe walking, or ask them to get up from the squatting position. Then for upper limbs, ask them to raise the hands above. See the eyes. In motor examination, probably you can check for the tone, the coordination, how is the grip, coordination you check while walking, and reflexes and Babinski is probably the last examination that we need to do. Okay, so all these things can be completed in less than 5 minutes. Again, you have to be selective and what you want to see and what you don't want to see. Okay, but again a word of caution, let's not be casual. If you find something that suppose तुम्हाला असं वाटलं की आपल्याला lesion brain मध्ये वाटलं होतं पण याच्या brain मध्ये जर काही तसं वाटत नाहीये, go back and review your diagnosis. So try to avoid spot diagnosis. Obviously you have to master your skill. When you say the reflex is exaggerated, you should be sure that you have checked it properly. Okay, when the reflex is absent, you should be sure that this reflex is really absent. So this skill you have to do again and again, then only you can be perfect in that. And again, your examination should match with your diagnosis. Suppose I am diagnosis something else and my examination is not matching, I have to go back and if my diagnosis is GBS and I see that the reflexes are flying, then that is not a GBS. Okay, so whatever is in your mind, that should be seen in your examination. If there is a mismatch, then there is something wrong. So if there are any deviations, you need to check it.
Excuse me, sir. 5 minutes left.
Okay, 5 minutes will complete. So somebody comes with a headache. What you have to see in a patient with headache? Just look at his eyes, whether there is any sixth nerve palsy. A fundus is important. See for any neck stiffness to rule out meningitis. See for the In case of stroke, look for any facial palsy, other cranial nerve examination, check for his power, do the motor examination, check the physiology, look at the BP, the heart sounds and the peripheral pulses. So these are the bare minimum things in 5 to 10 minutes you can complete, right? So facial palsy aaye ki nahi aaye. What is the power? The power, he has got drift, he is not able to lift, the power is 0. Whether the patient is ataxic or not, what is the blood pressure, how are his heart sound. So this much examination is important for a patient of stroke. So think like a neurologist, take a detailed history. While taking history, do your examination, watch your patient walk, ask him general questions, see his knowledge, see his emotions, see his intelligence, see how they are talking, look at the eyes, look at the face, and streamline your examination. This is how a neurologist does a neurological examination in his clinic in a short while. Probably in 10-15 minutes, the consultation is over. Okay, so it's easy, as I have told, practice makes it perfect. Make your own protocol. Sit in a day. आजच्या रविवारी आपण हेडेकच्या पेशंट मध्ये काय काय बघायचं ते ठरवूया. नेक्स्ट संडेला वर्टायगोच्या पेशंट मध्ये काय काय बघायचं ठरवूया. आफ्टर दॅट इम्बॅलन्सच्या पेशंट मध्ये काय काय बघायचं ठरवूया. सो इन 10 days 10 symptoms that commonly present you can make your own protocol की मला हे बघायचंय. याच्यावरून मी ठरवणार की मला MRI करायचा आहे, EEG करायचा आहे, NCV करायचा आहे. याच्यावरून ठरवणार whether I need to refer to a neurologist or not. Okay, so make your own protocols. The patients are very happy. त्या डॉक्टरांनी मला 15 मिनिटं तपासलं. At least they listen to me. म्हणजे प्रत्येक complaint they try to analyze it. They validated the complaint and the success rate is more than 90%. This is more than an MRI. There are certain strokes which can't be diagnosed on MRI, but they can be diagnosed on a neurological examination. Okay, then you can plan your investigations, and as a clinician, as a physician, it is definitely rewarding and you will feel proud of yourself. In head injury, probably history is important, whether it was a domestic fall or it is high velocity injury. Or not, but any head injury where the patient is unconscious, has got vomiting, has got an ENT bleed, or is
Thank you, sir. We as a general practice, as a practitioners association, find it difficult to do neurological examination, but today you made it very simple for all of us. Very much helpful lecture. Thank you so much, sir. With this, I hand over the charge to Chairman Dr. Dipali Moore madam.
I request all the delegates to please sit in the auditorium. You have a very interactive session, and only last one has remained, which is going to be very interactive. I really thank you, Dr. Nilesh Parasdevkar, sir, for this simple and very practical about the tools you have told us and the gate you have told us. It was really very helpful in the GP practice. I request Dr. Shivaji Kolle to come on the dais to felicitate our speaker and chairpersons. Dr. Nilesh Parasdevkar. Dr. Ganesh Nimbalkar. And Dr. Sayani Gandhi. Thank you, all of you. For next lecture by Dr. Mankar sir, Doc He has done his BHMS CCMP and he is a practicing family physician at Deshmukh Clinic at Shirwar since last 30 years. He is recipient of Best Clinic and GP of the Year award. He is past president of Nira Valley Doctors Association. Dr. N.V. Kulkarni, he is practicing at DSK Vishwa. He is managing committee member of GPA. He has been editor of GPA newsletter for so many years. Dr. Manasi Pahade, she has done her BHMS and BA in Yoga. She is family physician and yoga teacher. She is member of Mukta Charitable Foundation. I request Dr. Deshmukh sir to take over.
देवियों और सज्जनों, नमस्कार. स्पेसिफिकली 3 देवियों, रूपा मॅडम, दीपाली मॅडम अँड मनीषा मॅडम. खूप काही सायंटिफिक सेशन आणि खूप काही इंग्लिश आपण ऐकलंय सकाळपासून. आता जरा रिलॅक्स होऊया, मस्त मराठीत गप्पा मारूया. ही वेळ खरं चहाची आहे, पण चहाच्या एवढंच उत्तेजक असं काहीतरी आम्ही तुमच्यासमोर घेऊन आलेलो आहोत. पीडियाट्रिक पल्स ऑफ विजडम म्हणजे ज्ञानरूपी शब्दांचे मोती. हे शब्दांचे मोती उधळायला आज आपल्या समोर विराजमान आहेत अतिशय लोकप्रिय पेडियाट्रिशियन आणि जीपीचे लाडके टीचर डॉक्टर संजय मानकर सर. सगळ्या पुणेकरांना आपल्याला गणपतीच्या मिरवणुकीची माहिती आहे. मिरवणूक उशिरा सुरू झाली की शेवटचे गणपती पळवायला लागतात. आमचा मानाचा गणपती आहे. थँक्यू. मंडळ आपला आभारी आहे. आम्हाला थोडासा वेळ द्या. आपल्या सर्वांनाही विनंती आहे, शनिवारची ओपीडी असते, पण एक 10 मिनिटं आमच्याकरता बेअर करा अँड यू विल नॉट रिग्रेट. आजच्या सेशनचे पहिले रूल्स पटकन सांगतो. दिस इज गोइंग टू त्या केसच्या संदर्भामध्ये ऑडियन्सला क्वेश्चन पोज केला जाईल. त्या क्वेश्चनचं उत्तर आपण तिथे हात वर करून किंवा जागेवर उभं राहून तिथे थांबायचे. आमच्यातले पार्टिसिपंट तुमच्या जवळ येतील आणि तुम्हाला माईक हँडओव्हर करतील. त्या माईकवरती कमीत कमी वेळात आणि कमीत कमी शब्दामध्ये तुम्हाला याचं उत्तर द्यायचं आहे. आणि या प्रत्येक केस संदर्भामध्ये मानकर सरांचं एक्सपर्ट ओपिनियन नंतर आपण ऐकणार आहोत. सगळ्यात शेवटचं महत्त्वाचं म्हणजे एक रॅपिड फायर राऊंड आहे. अतिशय आकर्षक चित्तवर्धक अशी काही चित्र तुम्हाला दाखवली जातील आणि त्या चित्राचं तुम्ही डायग्नोसिस करायचं आहे आणि ट्रीटमेंट हे सगळं एका वाक्यात द्यायचं आहे. सो लेट्स बिगिन. मी ओव्हर टू डॉक्टर मानकर सर.
Very good afternoon to all of you. Can you hear me all? Yeah. So very good afternoon to all of you. At the outset, I would like to thank the organizers of this mega GPCON, especially Dr. Agarwal madam, Dr. Deshmukh sir, Dr. Praveen sir, for the invite as well as the opportunity. This session, as sir has already told, is going to be an interactive session, and all of you are going to interact. This is the last session, so let's extend for 5-10 minutes, no problem. But all of you please interact with it. All these three chairpersons have taken a lot of efforts for this lecture. They have taken more efforts than me. So please give a big hand to them. So over to Deshmukh sir.
थँक्यू सर. केस चालू करतोय. दिसत असेल तर लाईट असू दे, कारण मग इंटरॅक्टिव्हला असू देत. म्हणजे
I think sir, everybody is able to see.
2 वर्षाचं बाळ आहे. फीवर आणि कॉफ याच्याकरता माझ्याकडे आलं. पहिलाच दिवस होता, तापाचा सिम्पटमॅटिकली ट्रीट केलं अँड आफ्टर 2 days दी बेबी वॉज रिलीव्ड. दुसऱ्या 2 दिवसांनी ते दाखवायला आलं बाळ. त्यावेळेला याच्या बरोबरीने पहिल्या दिवशी आलं तेव्हा बाळ जरा तापाने फणफणलं होतं. दुसऱ्या दिवशी आवाज काहीतरी वेगळा काढत राहतो. मग मी त्यांना विचारायला सुरुवात केली की बाळाला हाक मारली तर काही वेळेला आवाजाला प्रतिसाद मिळतो, नाही मिळत. मला एक प्रश्न पडला की बाळाला नक्की ऐकू येतं का? ती म्हणाली उलट असं आहे की एकदम मोठा आवाज झाला, फटाक्याचा आवाज झाला, हे झाला तर एकदम बाळ किंचाळून रडायला लागतं, एकदम अस्वस्थ होतं. मग बोलता बोलता मला लक्षात आलं की तुम्हाला मी आधी बघितलंय ना या बाळाला, तुम्हाला काही मी सांगितलं होतं का? मग केस पेपर्स बघायला लागलो. तर 15व्या महिन्याच्या MMRच्या व्हॅक्सिनच्या वेळेला हे बाळ माझ्याकडे आलं होतं. त्यावेळेला अशीच हे होती की ती काहीतरी बॅबलिंग करते, नीट बोलत नाही, एखादा शब्द बोलत नाहीये. त्यांना म्हटलं हे मला काहीतरी जरा वेगळं दिसतंय. आपल्याला केस हिस्ट्री बघितली बाळाची, बर्थ हिस्ट्री नॉर्मल, फुल टाइम नॉर्मल डिलिव्हरी, 3 किलोचं बाळ, 3ऱ्या-4थ्या महिन्याला मान धरायला लागलं, 6व्या-7व्या महिन्यात बसायला लागलं, 10व्या-11व्या महिन्यात उभं राहायला लागलं, नंतर चालायला लागलं. पण बोलण्याचा मात्र प्रॉब्लेम. आणि मग हळूहळू काही गोष्टी कळायला लागल्या. मग त्यांना मी असं म्हटलं की बाबा हे वेगळं काहीतरी दिसतंय तर आपण इन्व्हेस्टिगेट करून घेऊया. मला त्यावेळेला वाटलं की किमान बेरा तरी केली पाहिजे. हे नक्की ऐकू येते का नाही येते, थायरॉइड फंक्शन टेस्ट केले पाहिजे. आणि या संदर्भामध्ये मी त्यांना म्हटलं की बाबा आता तुम्हाला मी शिरवळला काम करतो, तुम्हाला पुण्याला जावं लागेल, भारतीमध्ये ऑडिओमेट्री करू, स्पीच असेसमेंट करू आणि ते सांगतील त्याप्रमाणे पुढचं करू. या सगळ्यामध्ये नेहमीप्रमाणे हे सगळं सांगितल्यानंतर त्यांनी डॉक्टर बदलला आणि नेमकं त्याच वेळेला कोरोना सुरू झाला आणि डिस्ट्रिक्ट बॉर्डर सील झाली. त्यामुळे बाळाला इकडे येताच आलं नाही आणि त्यामुळे हे 15 महिन्याचं बाळ डायरेक्टली 2 वर्षानंतर आज माझ्याकडे आलं आणि ते आलं त्यावेळेला सगळं अशा स्थितीमध्ये होतं. मला सरांना असं विचारायचं की त्या 15 महिन्याच्या वेळेला मी काही सस्पेक्ट केलं त्यावेळेला स्पीच असेसमेंट म्हणजे नेमकं काय, 2 वर्षाच्या बाळाचं काय स्पीच असेस करायचं, त्या संदर्भात आम्हाला तुम्ही काही सांगाल का?
Speech assessment, usually the speech will start right from the beginning. At just around 6 to 8 weeks, the baby will start cooing. Normal cooing sound start totally. At around 6 months, they start फर्स्ट मिनिंगफुल वर्ड जो आहे तो 9 मंथला यायला लागतो. मिनिंगफुल वर्ड ॲट अराउंड 18 मंथ त्यांचे 10 ते 20 शब्द ते मिनिंगफुल बोलू शकतात. अराउंड 2 इयर्स ते 2 शब्द कंबाईन करतात, आई दे, मला घे, इकडे चल, असे रुटीन शब्द ते 2 वर्षाला कंबाईन करतात आणि त्यांना जवळजवळ 40 ते 50 शब्द मिनिंगफुली 2 वर्षाला येऊ लागतात. अराउंड 2.5 इयर्स त्यांना जवळजवळ 200 ते 250 शब्द यायला लागतात आणि ते 3 ते 4 शब्दाचं वाक्य तयार करू शकतात. एवढा अर्थ आई मला घेऊन चल असं 4 शब्दाचं वाक्य सुद्धा ते 2.5 वर्षाला तयार करू शकतात. अराउंड 3 इयर्स दे कॅन स्टार्ट टेलिंग यू स्टोरी आणि 4 वर्षाला तर पूर्णच्या पूर्ण लँग्वेज, फुल स्टोरी लँग्वेज त्यांना चांगली येते. तर हे ठराविक स्पीच असेसमेंट आहे ते आपण ट्राय टू डू इट ॲट एव्हरी विजिट. तर जस्ट फक्त सर्दी खोकला ताप पकडण्यापेक्षा आपण ते पण बघितलेलं कधी पण चांगलं की बोलतो की नाही.
सर तुमचे स्लाइड्स दाखवाल का?
नो प्रॉब्लेम. सो दीज आर द रेड फ्लॅग्स. आपल्याला कधी कळलं पाहिजे की या बाळाला काहीतरी प्रॉब्लेम आहे. तर नो बॅबलिंग बाय 9 मंथ, दातात सुद्धा म्हणता येत नाहीये 9 महिन्याचं होईपर्यंत, दॅट इज डेफिनेटली अ प्रॉब्लेम. आपण म्हणलं आता की पहिला शब्द 10 महिन्यालाच आला पाहिजे, जवळजवळ 9 ते 10 महिन्याला, पण 15 महिन्यापर्यंत एक पण शब्द बोलता येत नसेल तर डेफिनेटली प्रॉब्लेम. नो कन्सिस्टंट वर्ड बाय 18 मंथ, देन नो कॉम्बिनेशन. आपण म्हणलं मला दे, मला घे, सुद्धा बोलता येत नाही 2 वर्षाला तर प्रॉब्लेम. देयर इज अ प्रॉब्लेम इन अंडरस्टँडिंग ओन चाइल्ड लँग्वेज. आईला स्वतःचं बाळ काय बोलतं हे कळत नाहीये 2 वर्षापर्यंत तर प्रॉब्लेम. आणि 3 वर्षापर्यंत समोरच्या माणसाला कळत नाही delayed in speech. The first most thing sir has already told, you have to do a hearing assessment. Normally हिअरिंग असेसमेंट करून घेणं अतिशय गरजेचं आहे. आता बहुसंख्य हॉस्पिटलमध्ये, मेजर हॉस्पिटल्समध्ये हिअरिंग स्क्रीनिंग प्रोग्राम हा सुरू आहे. प्रत्येक हॉस्पिटलमध्ये ज्यावेळेला डिलिव्हरी होते त्याला OAE नावाची टेस्ट केली जाते आणि त्याच्यातून आपल्याला अंदाज येऊ शकतो की बेबीला बेबीला ऐकू येते की नाही. त्याच्यात लिहिलेलं असतं OAE पास ऑर फेल्ड. जर OAE फेल्ड असेल तर यू हॅव टू डू अ बेरा इमिजिएटली. बेरा करून आपल्याला कळतं की यांना खरोखरी ऐकू येते. त्यानंतर साधारण मोठ्या बाळांचं तुम्ही ऑडिओमेट्री करू शकता, पण हिअरिंग असेसमेंट इज ॲब्सोल्युटली मॅन्डेटरी. इफ देर इज अ प्रॉब्लेम विथ द हिअरिंग, you have to go for some, whether it is a sensorineural deafness or whether it is a conductive deafness, त्याच्याप्रमाणे ट्रीट करावं लागेल. हिअरिंग एड लागेल किंवा कॉक्लिअर इम्प्लांट लागेल, दॅट इज अ डिफरंट थिंग. पण जर तसं नसेल, ठीक राहत काय. If there is no hearing loss at all, the child is absolutely otherwise looking fine. त्याचं आपल्याला डिटेल हिस्ट्री, आताच निलेश सरांनी सांगितलं की डिटेल हिस्ट्री आणि गुड न्यूरोलॉजिकल एक्झामिनेशन हॅज टू बी डन फॉर ईच अँड एव्हरी चाइल्ड. हेड सर्कम्फरन्स व्यवस्थित घेतला गेला पाहिजे. हेड सर्कम्फरन्स घेतल्यावर आपल्याला कळतं याला मायक्रोकिफॅली आहे का, मायक्रोकिफॅली काय आहे का. After a good neurological examination, so after good neurological examination, you will come to know whether the child has got spasticity, any reflexes, any problems. So if it is there, abnormal neurological examination is there, this can be a dysarthria, difficulty in articulation. With the autism.
आईच्या पदराला धरून त्या आईला तिथे घेऊन जातो आणि मग हावभावाने सांगतो की मला ही वस्तू पाहिजे. आता त्या आईला सवय झाली होती त्या हावभावांची की काय त्याला नेमकं हवंय. एकाच प्रकारचा आवाज काढतं, म्हणजे आपण त्याच्याशी बोलायला लागलो आणि आपण जर काहीतरी छान असा शब्द वापरला, छान 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 असा इको येईल, असं इकोइक सारखं असतं. तेच रिपीटेड वर्ड्स असतात. त्याच्या आईने मला सांगितलं की अहो तुम्हाला काय सांगू, परवा मी एका बर्थडे पार्टीला गेले, त्याच्या बरोबरचं एक दुसरं 2 वर्षाचं बाळ होतं. सगळी बाळं एन्जॉय करत होती, पण हे एक बाळ एकटंच आपलं कोपऱ्यात बसलं होतं. एक चेंडू घेतला आणि चेंडू हातात घेऊन फिरवत बसलं. बाकी सगळ्यांकडं ते रिटर्न गिफ्ट्स मिळाल्या, त्या बाळाचं त्या रिटर्न गिफ्ट्सकडे लक्ष नव्हतं, खाण्याच्याकडे लक्ष नव्हतं. चित्राचं एक पुस्तक दिलं तर ते चित्र बघण्याच्या ऐवजी ते नुसतं एक पान उलटायचं बंद करायचं, उलटायचं बंद करायचं, असं करत होतं. प्लेटमध्ये खाऊ दिला तर नीट खात नव्हतं. त्याला स्वतःला कोऑर्डिनेशन खाण्याचं जमत नव्हतं, सांडून बरबटून ठेवतंय हातात. आय पोज अ क्वेश्चन टू द ऑडियन्स. हे सगळं काय असेल असं तुम्हाला वाटतं? कृपया हा.
ऑटिझम सर.
बाकी कोणाचं काही वेगळं मत आहे? बाळ
ऑटिझम स्पेक्ट्रम डिसऑर्डर ऑल्सो सर.
बर. सो आता याच्यावरती आपण हा नाही, स्लाइड नसती तरी कदाचित लक्षात आलं असतं. ठीक आहे, पण आता हे आपल्याला समजा कळलंय की आपल्या वी आर थिंकिंग इन टर्म्स की हे कदाचित असू शकेल. पण मी सरांना विचारतो, सर ऑटिझम म्हणजे नक्की काय आणि ऑटिझमचे काय की फीचर्स आहेत जे आम्हाला ऑफिस प्रॅक्टिसमध्ये आमच्याकडनं मिस होता कामा नयेत, तेवढं प्लीज सांगा.
Autism is a problem where you have problem with the communication. So communication may be a verbal communication, म्हणजे बोलण्यामध्ये प्रॉब्लेम, or it may be a problem with a non-verbal communication. Non-verbal communication म्हणजे आपण समजा जरी बोलत नसलो तरी आपण आपला चेहरा बोलका असतो, आपले डोळे बोलके असतात, आपण समोरच्याशी इंटरॅक्ट नुसतं नजरेने केले तरी इंटरॅक्ट होऊ शकतं. तर ते नॉन व्हर्बल कम्युनिकेशन पण हे ऑटिझम मध्ये नसतं. So there is a problem with the verbal as well as non-verbal communication. So they don't form communication with the others. They don't form friends at all, and there is a repetitive behavior. हे तीन गोष्टी त्याच्यात महत्त्वाच्या असतात. The first important thing is, as sir has already told, there is a delayed speech. There is a delayed speech. Delayed speech आता आपण सांगितलं की या गोष्टी ठराविक याच्यात झाल्या पाहिजे, त्या तर होत नाहीत. अँड दे डोंट रिस्पॉन्ड. आई सांगते की हाला हाका मारली तरी हा लक्षच देत नाही, त्याला कधी कधी लक्ष देतो पण बहुसंख्य वेळा तो माझ्याकडे लक्षच देत नाही. त्याला टीव्ही बंद केला तरी लक्ष देत नाही, मोबाईल स्क्रीन बंद केली तरी लक्ष देत नाही, त्याला ज्या वेळेला पाहिजे त्यावेळेला तो लक्ष देतो. तर दॅट इज जर कोणी आपल्या नजरेला नजर देऊन बोलत नसेल ते बाळ, फिंगर पॉइंटिंग. एखाद्या बाळाला आता आई दाखवत असते, अरे तो बघ हत्ती चाललाय, तर तो हत्ती चाललाय तर तो हत्तीच्याकडे बघतच नाही बाळ, त्या आईच्या फिंगरकडेच बघत राहतो. त्याला पॉइंट करायचं. आता समजा हत्ती आलाय तर तो दाखवत नाही कधी हत्ती आलाय, तो आईला किचन मधनं ओढून घेऊन जातो पदराला घेऊन आणि या 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 म्हणजे त्याला आता आई बघ बाबा तू हे हत्ती आलाय. सो देयर इज नो पॉइंटिंग ॲट ऑल. त्याला काही दाखवायचं की हा फॅन बघ, तो फॅनकडे कधीच बोट दाखवणार नाही. सो absence of pointing is very important sign of autism. Reduced responsiveness to the other people's facial expression. कोणी त्याच्याकडे बघून हसलं तर तो कधीच हसणार नाही, तो दुसरीकडेच बघणार. कोणी त्याला असं घाबरवण्याचा प्रयत्न केला तरी तो घाबरणारच नाही म्हणजे तो दुसरीकडेच बघत राहणार. सो दॅट इज अगेन अ साइन ऑफ ऑटिझम. इकोलॅलिया आत्ता सरांनी म्हणलं, एकच शब्द सारखा सारखा म्हणत राहत. आई म्हणते हा बोलतो की, पण काय बोलतो तेच शब्द परत परत बोलतो. त्याला एखादी वस्तू हवी असेल तर मला दे असं काही कधी म्हणणारच नाही, मला ते म्हणणारच नाही. तर आई देते आई देते आई देते असंच म्हणणार, कारण तेवढंच त्यांनी सांगितलेलं असतं आई देते. तर सॉल इकोलॅलिया विच इज देअर, सेम वर्ड विल बी रिपीटेड अगेन अँड अगेन. अबसेंट सोशल इंटरेस्ट, आता सरांनी सांगितलं की सगळे खेळत असतात पण हा काही खेळत नाही. तर तो काय करतो, पॅरलल प्ले. म्हणजे सगळे त्याच्यावर, समजा 5 वर्षाचा मुलगा आहे, 5 वर्षाचा मुलगा, सगळेजण क्रिकेट खेळत आहेत, तर हा काही त्यांच्यात खेळणार नाही. हा काय करणार, त्यांचा बॉल घेणार आणि स्वतःच एकटा खेळत राहणार. दॅट इज पॅरलल प्ले. दे डोंट प्ले विथ द अदर्स. सो दॅट इज अगेन अ साइन ऑफ ऑटिझम. absent enjoyment in situation that most children like. आता सरांनी सांगितलं की बर्थडे पार्टीला गेला पण बर्थडे पार्टीला तिथे काहीच एन्जॉय नाही केलं. सगळे खेळत होते, हा एकटा कोपऱ्यात बसून होता. दॅट इज अगेन फेल्युअर टू रिस्पॉन्ड टू नेम. आपण आता म्हटल्याप्रमाणे प्रिफर टू बी अलोन. तो कायम एकटाच राहायला बघतो. डझंट मिक्स. Can be diagnosed as early as 1 year of age, but as the age advances, you will be able to, most of the time, autism. Next thing is the repetitive behavior and stereotypic movements of the play. Repetitive behavior म्हणजे काय? तर तसं एका ठिकाणी उभा राहिला तरी नुसतं असंच करतात किंवा असंच करत राहील. So that is repetitive behavior. Same behavior again. And repetitive play. त्यांचा प्ले काय तर फक्त दार बंद करायचं, दार उघडायचं, दार बंद करायचं, दार उघडायचं, एवढाच प्ले. किंवा एखादा फ्लावर पॉट असेल तोच असा फिरवत बसायचा, टेबल हे असेल पेपर वेट असेल तोच फिरवत बसायचा. त्याला अख्खी कार दिली तर त्या कारमध्ये इंटरेस्ट नसतो, तो कार घेतो आणि फक्त चाक फिरवत राहतो. So this is again a very important feature of the autism. Upset when routine is changed. त्यांचं रुटीन जरा जरी बदललं, जरा शर्ट दुसरा घातला वेगळा तरी तो एकदम अपसेट होऊन जातो. दॅट इज अगेन अ साइन. लॅक ऑफ कॉर्डिनेशन अँड क्लमझीनेस. तो क्लिनिक मध्ये आला तर धुडगुसच घालतो. आई म्हणते खूप धांदरट आहे, कुठेही गेला तरी तोडफोड करतोच. कॉर्डिनेशन लॅक. जाता जाता क्लिनिक मध्ये खुर्चीला धडक, इकडेच काहीतरी धाडकन आपट, असं तर क्लमझीनेस त्यांच्यामध्ये खूप असतो. अग्रेसिव्ह बिहेवियर. दुसऱ्यांच्यात खेळायला गेला तर त्यांना मारूनच येतो. शॉर्ट अटेन्शन स्पॅन, फसी इटिंग हॅबिट, आणि लास्टली ओव्हर रिॲक्शन टू द सेन्सरी स्टिम्युलस. म्हणजे काय तर त्याला चव आवडली नाही तर डायरेक्ट तोंडावर थुंकायला पण कमी करणार नाही, किंवा चव आवडली नाही तर एकदम चोकिंग होत आहे असं दाखवेल. तो ही रिस्पॉन्ड व्हेरी वेगली टू द सेन्सरी स्टिम्युलस. एक
वाटलं
okay.
दिलं
So
पण
this is a very good pamphlet you can display in your waiting rooms, so the mother can read this and come to know whether her child is autistic or not. So what is the take home message from this case is autism is very may grow as a normal adult. आपल्याकडनं जर लेट झाला खूपच त्यांना पिकअप करायला तर लॅटर ऑन दे मे हॅव लॉट ऑफ त्यांच्या एम्प्लॉयमेंट मध्ये प्रॉब्लेम येऊ शकतात. दे मे नॉट फॉर्म ॲट ऑल अ व्हेरी गुड फ्रेंड्स. So depression, anxiety, lots of other problems will also occur. So you have to pick them as early as possible, as around 18 to 24 months.
सर जस्ट अ पासिंग रिमार्क वेल क्लोजिंग. त्याच्या सिबलिंग विषयी काय? हे पहिलं चाइल्ड आहे, दुसऱ्या बाळाच्या बाबतीत काय काळजी घ्यायला पाहिजे, काय बघायला पाहिजे?
Second baby can be autistic, so you have to screen them as early as possible. And if you have neurological problems associated with autism, like sometimes you have abnormal neurological examination, microcephaly, campylate spot, dysmorphic features, you may have to go for genetic testing.
Okay.
Genetic testing.
थँक यू सर, थँक्स अ लॉट. नाव बी फिनिश द फर्स्ट केस. मी मानसी मॅडमना पुढच्या केस करता आमंत्रित करतो. धन्यवाद.
Yeah. They definitely get, if the retardation is too much, they definitely get as a disabled certificate. You can, after 5 years, if they are severely problem with the verbal communication, they can definitely. And there are different schools for them also, if they are severely affected.
Greetings of the day. It has been a busy day and we are with the most interesting final session. I am going to present you a case on high grade fever. So this is
This
My
is one of
case-
the commonest case that you face in your office practice. That's why ma'am has this case. So let's see how everybody reacts to it.
A 9-year-old boy comes to a family physician with the complaint of high-grade fever with chill from the previous day. He also had headache and throat pain. Vitals were normal, but fever. So my question to audience is it a right choice of the treatment? Yes, anybody?
उभं राहून त्याची उत्तर द्या.
हात वर करा.
Specific.
Is it right choice of treatment, and was it okay to start antibiotic on first visit?
No need to no need to
This is most likely viral infection because their first fever is 103 and general complaints are fever plus throat pain. So we start only on paracetamol and symptomatic, and if no relief, then after 3 days do hemogram and then after start antibiotic.
Okay.
Anybody else?
Anybody else?
Dharak sir.
क्लिनिकली बघायला पाहिजे वाटतं. तर घसा दुखतं म्हटल्यानंतर टॉन्सिलायटिस वगैरे असू शकतं. ते बघूया आणि मग ठरवूया असं वाटतं.
एक छोटी सूचना, वाघ सर आणि दर्ग सरांनी बोलणं झालं त्यामुळे परत त्यांनी हात वर करू नये. एकाने एकदाच बोलायचं.
नवीन लोकांनी हात वर करावेत. अजून आहे कोणाला काही सजेशन द्यायचंय?
My question to Mankad sir. Sir, what is the rational treatment of fever?
Okay, rational treatment of fever is first thing to find out the cause of fever. Fever कशामुळे येते? So antibiotics are not antipyretic. So the first most important thing is you have to find out the cause of fever. So here this child has come with high grade fever on day 2, has got a headache and has got a throat pain. So you have to rule out first meningitis is not there. Headache is there. The child has got meningitis. So kindly look for all meningeal signs. We have just finished with the neurological examination. So is it a meningitis?
पण सर इथे वॉमिटिंग नाही आहे ना? वॉमिटिंग नाही आहे सर इथे.
No vomiting.
Yeah.
Yes.
So that's what. If the child clinic examination is normal, everything is normal, you may just prescribe antipyretic. But if the child has got any signs of toxicity or suggestive of a bacterial infection, or there may be a membrane formation, or there may be a submandibular jugular acid. There you definitely can start antibiotics even on it.
Yes. Sir, next slide, please.
And what about ibupara combination?
Yes. What about ibupara combination?
She asked about the management of fever. Yeah, the drug of choice is always plain paracetamol. Try to prefer only plain paracetamol. Why? Because paracetamol is very good drug. It has got high safety profile. So even if you exceed the doses, it will not cause any problem. Second thing, if you are giving paracetamol in the right dose, that is 15 milligram per kg per dose, and the child's fever is not coming down with that, indicates the child has got some serious problem.
Sir, what about mefenamic acid?
Yes, I prefer to give only paracetamol and not mefenamic acid. Mefenamic acid is commonly associated with other side effects, like it may be associated with hematuria. You must have commonly seen hematuria associated with, so renal injury can occur, especially if the child is dehydrated and you have given mefenamic acid. Kidney perfusion is also reduced, and over that if you are given mefenamic acid can really cause hematuria and acute nephritis.
Sir, can
to avoid yes.
Sir, can paracetamol be given earlier than 6 hours?
Paracetamol can be given every 4 hours. Can be given every 4 hours. try to avoid ibuprofen also because it causes a lot of gastritis. If this child turns out to be dengue and low platelets, he may have a gastritis, vomiting, and that. So try to prefer only paracetamol as a fever.
Yes.
Yes, so that's what I'm saying. If the fever is not coming down with the paracetamol, it takes routinely 2 hours for fever to come down with the paracetamol. You have to give in a proper dose, and the child has now nothing is going to happen. You have to diagnose what the fever is.
Sir, nimesulide.
Do you get nimesulide? You get? I don't know. But nimesulide is a banned because of hepatotoxicity, nephrotoxicity, and sudden hypothermia. Sudden hypothermia म्हणजे fever इतका पटकन खाली येतो 95 ला पण जातो. So it is banned drug. I don't know whether you get nimesulide or not.
Sir, how many doses has to be started when patient is complaining of fever? How many doses shall we give? 1 TDS or 1 QID?
SOS.
SOS only. Otherwise, we don't have to.
There is no round the clock paracetamol. It
Okay.
has to be given SOS when the fever is there. If the fever is not coming with the 1 dose, second dose after 4 hours.
Okay, fine. Thank you, sir.
Definitely. That's the rational treatment. It's not only because body produces fever to kill the germs. If it is only above 100, we try to give it. Otherwise, don't. Because all defense mechanism of the body are going to be activated at 100 degrees. Yeah, the child who are not taking orally, the preferred treatment is a suppository. Or especially the child has come to in convulsive status, definitely rectal suppository. Paracetamol rectal suppository is a drug of choice.
So, if patient is having febrile, if is having history of febrile convulsion, so should we wait to raise the temperature above 100 or?
In that condition, whenever there is a history of febrile seizure, you try to lower the temperature as early as possible by giving, doing tepid sponging also, by lukewarm water and giving a paracetamol. If you really are too much worried, sometimes the parents are too much worried, in that condition you may prefer ibu para combination, but I will going to happen with the oral paracetamol, try to do as for oral only. If oral is not given by any reason, injectable paracetamol, it's safe. It is safe.
Yes. So the patient was called for follow-up on day 3. His complaints had increased. He had fever with chills, vomiting, abdominal pain, and occasional loose motion. On examination, oral mucosa was reddish. Conjunctiva, there is congestion but no discharge. An appearance of maculopapular erythematous rash. Abdominal exam was done. It shows hepatomegaly. Liver was 2 centimeters. So there are next slides of rash. Maculopapular erythematous rash on abdomen and back and hand. So what could be the differential diagnosis now?
Yes.
Anybody?
मिझल्स आणि डेंग्यू असे 2 पर्याय आलेले आहेत आपल्या समोर.
Yes.
ड्रग इंड्युस्ड झालं त्यांचं.
आणि काय कोणाला सांगायचं आहे?
ड्रग इंड्युस्ड आपण इथे काय फक्त पॅरासिटामॉल अमॉक्सिक लावतील ना.
Yes.
Okay.
So patient
Please
was
proceed.
asked to go for some investigation. Sir, next slide. Yes.
तेच तुम्हाला विचारलं जरा सर.
Yes. So hemoglobin 12.
So we ask you the differential diagnosis actually. So it can be still measles also. It can be simple viral exanthematous rash also, or it can be
dengue.
You can hear me, na? Yeah. It can be dengue also, or it can be a drug rash also.
Yes, sir.
So viral infection may include anything, including infectious mononuclear.
So hemoglobin 12 gram, total count increased 18,000. Viral positive and dengue profile negative. Urine
Yes.
Yes.
But everybody's diagnosis was dengue, but dengue is negative. Can this still be a dengue-like fever?
No, no. If NS1 IgG IgM is negative, probably.
Dengue
It was
profile
done by slide
pura,
test.
it was negative.
Vidal, obviously, you cannot do it in the first week, probably. It has to be done later.
The liver was 2 centimeters. It may be viral hepatitis also.
Yes, one by one, please.
Hello?
Yes, the patient.
Malaria can be there, but see, it has not shown malaria. Why we don't think that this is a malaria? Peripheral smear is negative. Though the platelets are less, the hemoglobin has not dropped down. In malaria, definite drop down of hemoglobin will occur. And the pattern of the fever in the malaria is different. So clinically also you can judge. Next is sir, systemic examination normal होती पहिली सब. ती पण normal. फक्त हिपॅटोमेगॅली आहे 2 सेंटीमीटर.
Hepatomegaly आहे.
हिपॅटोमेगॅली आहे सर.
Oral mucosa reddish. Oral mucosa was reddish. Hepatomegaly was there.
Absolutely, sir is a very good clinician, so he just want to rule out that there is no meningitis. That's absolutely. Can be a
Yes,
COVID.
let us see. Yes, let us see, sir. Let us see, sir.
Okay, sir.
Kashavarun, sir?
I just ask you how many COVID you have seen Vidal positive, and how many COVID you are diagnosed by Vidal. Okay, fine. Then you should not do RT-PCR. You should not do RT-PCR and do Vidal. Great. Yeah, correct.
So the family physician advised hospitalization.
So one take-home message from this is you should not do a Vidal on the first week. Unnecessary wastage of money, and it will mislead you. It will rapid Vidal. That is also not done. It is another Vidal with a high cost. Higher quality, but at a higher rate. So same result. Interpretation is same because sensitivity and specificity both are less. So as sir has said, it has come positive in COVID. If the child is a TB, it is also will come positive. If it is a sarcoidosis, it will come positive. So thousands of conditions it is going to come positive. So you are not going to diagnose that condition by Vidal. That is also yes.
So the family physician.
Sir, you are right. You will come to know this later.
So the family physician advised hospitalization, but patient was reluctant to admit. And next day he came again. So next day he has high grade fever again 103, low volume pulse, pedal edema, BP hypertension was there 72/50. Capillary refill time prolonged. Usually it is 2 seconds, but it is more than 2 seconds in this case. And there is cervical lymphadenopathy. So what is the differential diagnosis now? Yes. And sir, I want to ask you the question, what are the red flags in this case now?
सर आता मोस्ट प्रॉबेबली सगळ्यांचं इन्फेक्शियस मोनोन्यूक्लिओसिस झालेलं आहे.
That's absolutely correct thinking. So if such case is there, you go back to the case and you will come to know that this child has come to you with very high grade fever right on a day 1. He has abdominal pain. he has also abdominal pain and vomiting. Nobody has thought of appendicitis. Yes, it can be appendicitis still, but the counts are also high. So it can be abdominal pathology. It can be just gram-negative sepsis. He had a throat pain. We have to think of streptococcal infection that can lead to shock. So streptococcal shock, toxic shock syndrome, which can be either streptococcal or a staphylococcal shock syndrome. Both can present like this, and even dengue. Dengue can present like this. In spite the dengue are negative, we have seen dengue-like illnesses. GPC count is high, which goes against the diagnosis of dengue. Anything above 15,000 goes against the diagnosis of dengue. Polymorphs, which again goes against the diagnosis of dengue. Only 16% of lympho, that also against the diagnosis of dengue. While dengue will always have a lymphocytosis. Sir was thinking of enteric fever, so eosinopenia can be a feature of enteric fever. Monocytosis can be a feature of tuberculosis. So all the things in this are very important, including dengue negative and all this. On the platelets, if it is an enteric fever, the platelets routinely fall in a second week of the illness, not in the first week of the illness. So that's again important feature, that on the third day only the platelets are reduced. So which can fit into dengue, but the other is not fitting. So this is something else. I'm not finding streptococcal scarlet fever also. I'm not finding staphylococcal infection anywhere. Counts are raised. This is not dengue. This is not infectious mononucleosis. Everybody's thinking infectious mononucleosis because rash is there. He has a liver of 2 centimeter, but atypical lymphocytes has to be there to call it as a infectious mononucleosis. Here the lymphocytes are very less. Lymphopenia is there. I'm not thinking of infectious mononucleosis also. You can do a VCA test for infectious mononucleosis, but this is not suggestive of that. So anybody has other diagnosis?
Sir, we'll have to go some bit hurriedly. We'll have to go a bit hurriedly, sir, because one more case to be presented.
Sorry.
So this patient was
So this
hospitalized.
child, if you see, he is in shock. He is in shock. His BP has gone down. Bed and release it. If it is filling within 1 or 2 seconds, it's normal. If the nail, it's prolonged. So CRT prolonged indicates he is in a shock. There is pedal edema also, like capillary leak and pulse low volume. So all suggest this is in shock. Okay.
Yes, sir. That patient was hospitalized.
So this patient was hospitalized and fluid resuscitation. Since hypotension is there, boluses of normal saline or ringer lactates were given, IV antibiotics were started. Still, there was no improvement in the blood pressure, so he was started on dopamine drip. So after hospitalization, his hemoglobin was 10.1. Now it has dropped. Counts are increased 22,000. Polymorphs 85 and lymphocytes have still gone down. Platelets have gone down now, and CRP is very high, 132. ESR is also very high. Now anybody has any differential diagnosis for this?
Yes.
Septicemia, absolutely correct. This can be sepsis. So that's what we are thinking of, either staph or streptotoxic shock syndrome, because there is a rash also. Yes. X-ray chest was a normal. So it was not mentioned here, but it is absolutely correct. USG abdomen shows only hepatomegaly. It is very difficult to on slide put everything, but it was normal. Yeah. abdominal lymph nodes were not there. Cervical lymph, sir, the child is 8 years old, so definitely he will have some kind of a meningeal involvement in the form of projectile vomiting, may will have in the form of neck stiffness, Kernig's, Brudzinski's sign, all will come positive, and by the time if you haven't treated, he will start convulsing.
So ferritin is
BNP is a test which is for a cardiac involvement. So if the cardiac indicate the cardiac contractibility is reduced, and that's why the child is in a shock. That's why the child is in a shock. So the echocardiography was done and it was showing myocardial dysfunction, and somebody has said rightly it can be sepsis. So blood culture was sent right on a day 1 before giving an first dose of an antibiotic. So it has come negative. COVID, somebody has thought, but the COVID PCR as negative, but antibodies have come strongly positive. So now what is the diagnosis? Everybody knows.
yes.
So diagnosis is multisystemic inflammatory syndrome, which is associated with COVID-19. So this is slightly new to everybody, but everybody has to know this because pediatric COVID infections, though are occurring, they are very milder form. Most of them will go unnoticed, or just somebody else in the family has come COVID positive. That's why you do it and they will come COVID positive, and they just require sometimes only paracetamol and nothing else. So this MIS, that is multisystemic inflammatory syndrome, is a rare complication of COVID. You need to know this because nowadays we have managed almost 50 cases in Bharati Hospital of this MIS. Early diagnosis is extremely important as it will save the life. If you are too late, the child's shock is beyond repairable, he will die. So early diagnosis and awareness of this condition that MIS exists is important. As it suggests inflammatory, you see all the inflammatory markers are very high. What are the inflammatory markers you see in the previous slides? So you see CRP very sky high, ESR very high, ferritin very high. If you do a fibrinogen, that is also, and mandatory to take blood pressure in a child who is running very high fever. Then only you will be able to diagnose this. So CRP thing which will suggest that this is MIS. So it is something new, so that if the child has come to with very high grade fever and rash, just don't think of measles because measles outdated. I hardly see measles nowadays. We are giving MR vaccine, MMR vaccine. So measles is almost reportable now. We hardly see any measles. Those who have not received vaccine, the measles is seen, and the rash of the measles classically will start below the hairline, behind the ears, and then will gradually go down. Will have a Koplik spots, will have all the features of measles, and as the rash reaches the lower extremity, the fever will fall by crisis. So that's the hallmark of measles. If it is a streptococcal infection, you will have a pharyngitis or a tonsillitis, and you will have a scarlet fever like rash, that is a sandpaper appearance of the rash. So the rash is also extremely important. Dengue, the rash will start on a day 3 and it will have a blanching maculopapular rash, and it will be a transient rash which will last for just 48 hours to 72 hours. So this is entirely a new condition. Start thinking of this in your practice, and instead of doing Vidal, please start doing CRP, which will be very high in MIS. So this is a take home message.
Yes, sir. This case had taken several twists, and it kept the physician wondering about the final diagnosis. I'm extremely thankful to Dr. Mankar sir for his guidance and to you, dear audience, for participative listening. Thank you again.
Sir, there is a request from
So,
the.
just 1 minute. So this is a WHO definition. So all of you should know that there is a WHO definition of this MIS. This MIS first case was noted in April in England, and gradually in India we have reported many cases. So this MIS will occur in 0 to 19 years child. If there is a fever, rash or bilateral purulent, non-purulent conjunctivitis, measles मध्ये नेहमी purulent conjunctivitis आणि एव्हिडन्स ऑफ कोॲग्युलोपॅथी दोन याच्यापैकी पाहिजे. त्याच्यानंतर सीआरपी आणि ईएसआर वाढलेलं पाहिजे. लाईक टॉक्सिक शॉक सिंड्रोम अँड एव्हिडन्स ऑफ COVID-19 इन्फेक्शन. म्हणजे आयदर आरटीपीसीआर पॉझिटिव्ह पाहिजे, पण मोस्ट ऑफ द टाइम आरटीपीसीआर विल कम निगेटिव्ह and in 70% you will have a positive antibodies only. So that's the diagnosis of MIS.
Sir, regarding
Thank you,
this,
sir.
regarding the third case, there is some request from the organizers. We would like to listen to you more, so we will drop that question and answer session of the audience.
जर
We will
सरांना
present
काही
the case
विचारायचं
and-
असेल.
आणि तुम्ही तुमच्या एक्सपर्ट कमेंट्स द्या. या केस करता आपण ऑडियन्सचं इंटरेक्शन बंद ठेवूया, म्हणजे आपल्याला लवकर करता येईल.
कारण वेळ आपल्याकडे कमी आहे आणि नॉर्मलच केस आहे, साधी केस आहे. सर, वन चाइल्ड कम टू मी फॉर लूज मोशन्स. I started him on Oflox plus Metro. Sir, is it the right choice of antibiotic, or what should I start?
Okay, so this child has come to with a complaint of loose motion of
With
only 1
irritability,
day.
yeah, with irritability.
It is important to ask what is the color of the motion and whether it is a bloody diarrhea. The indication for giving an antibiotic in a diarrhea is only one, that is a bloody diarrhea, and that has to be a visible blood in a stool. It is not a microscopic examination you have done and shows 5-6 RBCs. That's not a indication
Sir,
to
for
give a
how many days?
Yes.
Bloody diarrhea म्हणजे
diarrhea
बाळ
of
जर
severe-
प्रेशर करत असेल तरी सुद्धा ब्लड येऊ शकतं ना.
Yes. So
Huh.
any child coming to with a bloody diarrhea, or the child is severely protein energy malnutrition, or if you are suspecting cholera, then only give antibiotic. Otherwise there is no role of antibiotic in diarrhea. Most of them are viral, or even if they are bacterial, they are mainly because of the toxins and they don't need antibiotics. So Oflox Metro is not a correct choice. Why? First thing, Oflox will of a chronic diarrhea. So never use Metro in acute diarrhea. It will unnecessarily lead to vomiting. Right choice is, if it is a bloody diarrhea, only 2 drugs are recommended. One is a cefixime, 10 milligram per kg per day, or azithromycin, 10 to 15 milligram per kg per day.
But
So
if it-
nowadays the drug of choice is cefixime or azithromycin only.
But only watery diarrhea is there. What should we give?
So that is more likely to be, if it is a watery diarrhea, it is more likely to be a viral, ORS and zinc.
Zinc. Okay. Sir, this patient diarrhea stopped, came next day, no fever, started vomiting 8 to 9 times with irritability persistent. Not acute gastroenteritis.
So he was
Next day lose motion started.
So he was sent on ORS and
On them.
on them.
Yeah.
So next day he returned again, and that time he was looking very drowsy.
Drowsy, more irritability.
Yeah. He was looking dehydrated and abdominal
Yes.
distension. So just a 1 minute question to audience, what this can be?
Just a minute. There was
Only one.
tachycardia, no pulse, low volume,
So
grade
this
3
is,
dehydration.
yeah. So basically, this is not a gastroenteritis only. If you go back to the history, it has started with a loose motion of only 1 day. If it is a gastroenteritis, most of the time it will start as a vomiting first, followed by loose motion. Here it has loose motion started first, and next day the vomiting has started. And now the vomiting is so much that the child is too much dehydrated, and he has got abdominal distension.
Distension, mild
So
distension. Mild distension, electrolytes plus minus, normal. So what is your diagnosis?
and you look at the history, the child is persistently irritable. So it
Yeah,
occurs
that
because
is,
of the
I'm telling you.
severe abdominal pain. It is the vomiting that is the presentation. So the cardinal feature is extreme irritability, abdominal pain. The child just take both the thighs up on the abdomen and keeps on crying. In between that, the child is absolutely fine, looks playful and active. But as the disease advances, again, the child will become more and more dehydrated, and then he will land into sepsis and then can land into shock. So identification of intussusception is extremely important, and three things are there. Vomiting has to be there. Two, there will be a sometimes palpable lump, but if the child is persistently crying, you may not be able to palpate the lump, and a bloody or a sauce like stool will be there. Sauce sarke stool yetat, known as red currant jelly stool. So that can be mistaken for bloody diarrhea. But severe abdominal pain, vomiting, bloody stools is suggestive of intussusception, and you can see a target sign which is there. If you do a barium of this, so this is the report which is showing bowel in bowel appearance suggestive of intussusception, which is a ileocolic. And this is the classical barium appearance. You can see a claw sign. You can see this kind of a hand which is there. That is a claw sign which is highly suggestive of intussusception. So intussusception will occur more commonly. Any child coming especially in the winter season with abdominal pain and a vomiting can be intussusception. Intussusception commonest age group is 5 months to 2 years. It is rare after 3 years. It is rare after 3 years. If it occurs after 3 years, it is commonly associated with Meckel's diverticulum or some kind of a fibroma, or may be associated with some tumor or hemangioma. So above 3 years, it is more likely to be a secondary intussusception. Rotavirus vaccine is known to cause intussusception. That's why the vaccine is not given after the age of 6 months. So this is classical intussusception. If we are too late, we will definitely require surgery. Perforate inside, gangrene will occur, he will go in shock and may die. So to save one life, intussusception awareness is extremely important. So that's about
थँक्यू सर. सरांनी आपल्याला सगळ्या प्रत्येक याच्यातून आत्ता सुद्धा प्रत्येक लेक्चरच्या नंतर टेक होम मेसेजेस दिलेले आहेत. त्याच्यामुळे आता मी काही सांगत बसत नाही. आपल्याला ऑलरेडी उशीर झालेला आहे. मी फक्त सरांना आता आपल्याला फक्त रॅपिड फायर राऊंड टाईप त्या शेवटच्या 5 स्लाईड आहेत त्या आपण आयडेंटिफाय करायच्यात. आणि मी आत्ताच सरांना ऑर्गनायझर्सना आधी थँक्स म्हणतो की त्यांनी मला संधी दिली आम्हाला तिघांना. त्याबद्दल मी ऑर्गनायझर्स आभार मानतो. आणि मानकर सरांनी तर आम्हाला भरपूर वेळ दिला. सरांच्या एवढ्या बिझी शेड्यूलमधून त्यांनी वेळ दिला आणि आम्ही एवढं करू शकलो. त्याच्यामुळे मी सरांचे म्हणजे मनापासून आभार मानतो.
There are last 4 to 5 slides which are coming to your OPD daily. Diagnosis is only one,
but the treatment is different. So
आपल्याला
let's see what sir.
आपल्याला या ज्या स्लाइड्स आहेत तर आपण असं म्हणतो की कोणतंही स्किन लिजन शूच्या जागी सोपं आहे, सिलोडर्म मिक्सिम लिहून द्या लगोलगी. मग आपण डायग्नोज करत बसत नाही. आता आपण याच्याबद्दल सांगूया. फर्स्ट स्लाइड सर तुम्हीच.
Okay, so this is classical diaper rash. So the diaper rash is showing erythematous macular regions with few vesicles. The rash is distributed on inner aspect of thighs, on scrotum also, on genitals also, and sometimes on a pubic area. So where the rash classically occurs is a diaper area, where the diaper comes in a contact. But if you see properly here, okay, so these folds are spared. This is very classical about the rash. What you are using is a, which cream you are using? Okay. Siloderm and all contain zinc oxide cream. So zinc oxide along with white petrolatum is a commonly prescribed thing. So zinc oxide cream like Siloderm can be prescribed in this child.
And no combination, sir.
No
That's what
combination cream. We'll come to that. So this is again a typical diaper rash. See, the buttocks are involved. Here also you may prescribe only zinc oxide cream. Only zinc oxide cream. Okay, so now if you see this child, you have a involvement of the folds. So these folds are involved. Sometimes here also the folds are involved. So this is classically a candidial rash. This is classically a candidial rash. Here your Siloderm will not work. Your zinc oxide cream will not work at all. You apply 10 tubes, it will not work. Here you will have to give something like miconazole or a clotrimazole cream. But please don't prescribe along with beclomethasone, which is commonly done. We commonly prescribe Candid B attack. So why not B? Because Candida will get aggravated because of beclomethasone. Further, inflamed skin, because of the inflammation, the steroids are rapidly absorbed from the skin, and if you apply for the longer time, systemic toxicity also can occur. It will lead to hypopigmentation in that area and even scarring or atrophy of the skin in that area. So here the treatment of choice is only plain antifungal, no combination, plain antifungal. You may along with that prescribe zinc oxide cream.
Sir, any advantage of newer antifungals like fluconazole over the?
Try to restrict to a older because they are better still, like miconazole, clotrimazole. But if no response, you can prescribe fluconazole. Oral routinely not required, but if it is extensive,
Last slide.
it is not going.
So thank you very much for such a practical and simple and interactive lecture. Sir, question answers madna we learned a lot of things as always. I request GPA organizing secretary, President Dr. Rupa Agarwal to come on the dais to felicitate. सर ॲक्च्युली शेवटचा गणपतीचं विसर्जन होऊ नये असंच वाटतंय सगळ्यांना, बट वी आर रिअली हेल्पलेस. डॉक्टर संजय मानकर. डॉक्टर NV कुलकर्णी. Dr. Rajendra Deshmukh and Dr. Manasi Pahade. I request all the delegates, sir deserves a standing ovation. I request all the delegates to come tomorrow on time. We have many attractions tomorrow and sharp at 8 a.m. And thanks for your patience listening today. Tomorrow at Hotel JW Marriott, SB Road. Yes, first time it is going to be at JW Marriott.
एक 5 मिनिटं फक्त राहिले शेवटची 5 मिनिटं सगळ्यांना विनंती आहे एक 5 मिनिटं सगळ्यांनी थांब आजच्या प्री कॉन्फरन्सच्या स्टेज इन्चार्ज डॉक्टर दीपा वाघ मी मेगा जीपीकॉन ऑर्गनायझेशनचे चेअरमन डॉक्टर रूपा अग्रवाल यांना विनंती करतो की त्यांनी डॉक्टर दीपा वाघ यांचा सत्कार करायचा आहे डॉक्टर दीपा जोशी स्टेज इंचार्जच्या डॉक्टर दीपा जोशी डॉक्टर रूपा अग्रवाल मेगा जीपीकॉन ऑर्गनायझेशन चेअरमन त्यांचा सत्कार करतील प्री कॉन्फरन्स आजचे चेअरमन डॉक्टर दीपाली मुळे यांचा सत्कार मेगा जीपीकॉन ऑर्गनायझेशन चेअरमन डॉक्टर रूपा अग्रवाल करतील दुसऱ्या को चेअरमन डॉक्टर मनीषा खेडकर यांचा सत्कार मेगा जीपीकॉन ऑर्गनायझेशन चेअरमन डॉक्टर रूपा अग्रवाल करतील आणि एक सगळ्या ऑफिस बेअरांना नम्र विनंती आहे फोटोग्राफसाठी सगळ्यांनी थांबायचं आहे सगळ्या ऑफिस बेअरांनी डायसवर यायचं आहे आणि जीपे जॉईंट सेक्रेटरी डॉक्टर सुनील भुजबळ यांना वोट ऑफ थँक्स देण्याची विनंती करतो डॉक्टर सुनील भुजबळ
Hello. I, Joint Secretary GP Mega GPCON 2021. I thank all speakers, all chairpersons. I thank session in charge. I thanks chairman and co-chairman of pre-con. And our sponsors, MQR Pharma and team, Ocuventis. Thanks all. And please be with us tomorrow morning 8 a.m. in JW Marriott. Thanks all.
कृपया सगळ्यांनी उद्या सकाळी 8 वाजता JW Marriott सेनापती बापट रोड येथे वेळेवर उपस्थित राहायचं आहे अच्छा गुड नाईट शब्बा खैर